So we're now ready to resume. We're going to pick up our meeting with the pneumococcal vaccine session, and Dr. Lair, the work group chair, will introduce the session. Thank you.
Thank you, Dr. Wharton. Take two. I'd like to introduce you to the pneumococcal work group vaccines presentations. We have several presentations for you today. Next slide. I'd like to thank the members of the pneumococcal vaccines work group, including the ACIP members, ex officio members, the consultants, the liaisons. Next slide. And also all the CDC contributors and consultants, especially the CDC lead, Dr. Kobayashi. I want to show a lot of appreciation for all the hard work and effort that these people are putting into the work group. Next slide. This slide shows the incidence of invasive pneumococcal disease. And as you can see, in the early 2000s, it dropped, and then it got to a fairly low level around 2015. During COVID, it went down to a historically low level, but recently it started returning to a pre-COVID level. Next slide. This slide reminds you of what we've done in the last few years. The ACIP has approved the PCV15 and the PCV20 vaccines for adults. We then approved the PCV15 and subsequently the PCV20 vaccines for children. And then in between, we approved the PCV20 vaccine with an expanded indication for adults who previously received PCV13. Next slide. This is a very interesting slide. The top three rows have PCV15, PCV20, and PPSV23, and you can see the serotypes that are in each of those three vaccines. There are two tentative vaccines that are in process of being tested. They're 24 valent, and you can see the extra 4 serotypes which are going to be included in those vaccines. But when you look at V116, which is the vaccine we'll be talking about today, it'll also be interchangeably called PCV21. You'll see that there's a significant change in the serotypes. There are approximately 10 serotypes in PCV20 that are not in PCV21, and I think there are 9 serotypes in PCV21 that are not in PCV20. So this is not just an additional serotypes to an already established vaccine. This is a totally different set of serotypes. Next slide. There are a couple of other additional pneumococcal vaccines under development. There's a 25-valent pneumococcal vaccine that has completed phase 2 testing, and a 31-valent vaccine, which is finished the enrollment of the phase 1 to 2 study. Next slide. These are the current recommendations that we have approved. So the following groups are currently recommended to receive a dose of pneumococcal conjugate vaccine: adults who are over 65 who have not yet received a PCV, adults 19 to 64 years with certain underlying conditions or risk factors who have not received a PCV, and then certain adults who have received PCV13 but have not received PCV20. Next slide. A key factor in the decision-making for the work group is that there are adults who have that risk-based vaccine recommendation. They have a lower vaccine coverage compared to those with an age-based recommendation. So specifically, if you look, age greater than 65-year-olds, almost 66% of them have received their PCV vaccine. But for adults aged 19 to 64 with risk-based indications, only about 22% of them have received their PCV vaccine. Next slide. So these are the policy questions that are being considered by the work group. And so specifically, should PCV21 be recommended for U.S. adults over 19 years, greater than or equal to 19, who currently have a recommendation to receive a PCV vaccine? So in other words, should we consider this as an alternative to the current vaccines, or in addition to the current vaccines? However, on the work group, there's also been discussion about expanding from a risk-based protocol for people under 64 and making it more of a routine recommendation or an age-based recommendation. So policy question number 2 is specifically for adults age 50 to 64 years who currently do not have a risk-based recommendation. And policy number 3 is extending it all the way down from 19 to 49 years. So this is what we'd like the ACIP work group to make sure they're thinking about when they're hearing the presentations today. Next slide. So the questions for the committee. Additional pneumococcal vaccines for adults are currently under investigation and may be approved in the near future. And there are dynamic changes in the pneumococcal disease incidence, which are anticipated post-COVID-19. And there's also been increased uptake in PCV15 and PCV20 in children and adults. Taking that information into consideration, do you have any feedback on the policy questions that we are considering in the work group? And what additional data would be helpful to inform the discussion on PCV21 use in adults? Next slide. These are the presentations that we'll be going over today, and I'll let you look at them for a second. And next slide. And I'll turn it back to Dr. Wharton.
So we will move on. Dr. Gehrke?
Hi, yes, can you hear me okay?
Yes, we can.
Great. Good afternoon. Today I'll discuss the current epidemiology of pneumococcal disease among adults in the United States. Next slide. We'll begin with a brief background on the spectrum of pneumococcal disease. We will then review pneumococcal vaccine coverage data in adults. Next, we will review pneumonia incidence estimates for adults, and we will finish by looking at trends of invasive pneumococcal disease, or IPD, examining the impact of COVID-19 and looking at IPD incidence and serotype distribution by the various vaccine types. Next slide. Pneumococcus is transmitted through airborne droplets from person to person. It can colonize the nasopharynx and can then spread locally to the ears to cause otitis media or sinusitis. It can also be aspirated and cause pneumonia in the lungs. Pneumococcus can also infect the blood and cause septicemia. Next slide. These different infections can be characterized into non-invasive disease, shown above the red line, and invasive disease, which is below the red line. Invasive pneumococcal disease is the less frequent but severe form of the illness, and it's defined as isolation of pneumococcus from a normally sterile site. Next slide. This slide shows coverage data from PCV15 and PCV20 among Medicare beneficiaries aged 65 years and older, ranging from October 1st, 2021 through December 31st, 2023. During this time, 12% of adults aged 65 years and older received PCV20. Coverage ranged from 9% among adults aged 85 years and older up to 25% among adults aged 65 years old. Only 0.2% of adults aged 65 years and older have received PCV15, with less than 1% coverage across all ages. Next slide. Dr. Lair presented some of this coverage information already, but I'll go into a little bit more detail here. As mentioned, looking at the National Health Interview Survey data, 65% of adults aged 65 and older have received a pneumococcal vaccine, while only 22% of adults aged 19 to 64 with a risk-based indication have received one. If we look at the breakdown by race, among the 19 to 64-year-old at-risk group, Hispanics and Asians both have significantly lower coverage compared to whites, who had the highest rates of vaccination. Next slide. In adults, pneumococcal pneumonia is the most common form of pneumococcal disease. As mentioned, IPD is less frequent but more severe. And in 2018 and 2019, the case fatality ratio of IPD among adults aged 65 years and older was 14%. Next slide. For the rest of the presentation, we'll look at IPD incidence and serotype distribution in adults. Next slide. Data on IPD are obtained from the Active Bacterial Course Surveillance System, or ABCs, which provides population-based surveillance at 10 sites across the US. Cases are defined as pneumococcus isolated from a normally sterile site in residents of the 10 surveillance areas, which are highlighted on the map in blue. Isolates are serotyped at reference laboratories using whole genome sequencing, quelling, or PCR. And US Census Bureau estimates were used as denominators to calculate the incidence rates for both overall and serotype-specific IPD, and will be presented as cases per 100,000 population. Next slide. This graph shows IPD incidence rates by age group from 2007 through 2022. Adults aged 65 years and older, shown in dark blue, have the highest rates of disease, followed by adults aged 50 to 64 years in yellow, then children aged less than 5 years in gray. And adults aged 19 to 49 in light blue have the lowest rates of disease among the age groups shown here. Next slide. After introduction of PCV13 in children in 2010, rates of IPD in children aged less than 5 declined sharply. Rates of IPD also declined in all adult age groups due to the indirect effects of vaccinating children. These declines plateaued around 2014, and rates have remained relatively stable through 2019. Next slide. No additional declines in IPD were observed after PCV13 was recommended for adults aged 65 years and older in late 2024. Next slide. And as mentioned, during the 2022 COVID-19 pandemic, rates of IPD declined sharply in all age groups to historic lows, but have since rebounded in 2021 and 2022. And among children less than 5 and adults aged 19 to 49 years, rates were back to pre-pandemic levels by the end of 2022. Next slide. Additionally, PCV15 and 20 were recommended for adults in late 2021, and PCV15 was recommended for children in 2022. Next slide. Among adult IPD cases, 82 to 87% had at least one risk-based indication for pneumococcal vaccination. The proportion of risk-based indication increased slightly with age. Next slide. This table shows the serotypes contained in the currently recommended vaccines, PCV15, PCV20, and PPSV23, and also those in the new vaccine, PCV21. Next slide. Due to the low uptake of PCV15 and the greater serotype coverage of PCV20, we wanted to directly compare the serotypes included in PCV20 to those in PCV21. Additional data are available on PCV15 and PPSV23 in the supplemental slides provided. Next slide. PCV20 contains 10 serotypes that are not included in PCV21. These are shown in light blue, and we'll refer to these as PCV20, non-PCV21. Next slide. PCV20 contains 10 serotypes that are also included in PCV21, shown here in gray. We will refer to these as PCV20 and PCV21. And here, note, we also include 6C due to cross-protection from the 6A antigen included in the vaccines. Next slide. Lastly, PCV21 contains 11 serotypes not included in PCV20, shown in orange. We will refer to these as PCV21, non-PCV20. Next slide. These graphs show the incidence of IPD among adults aged 19 to 64 years, grouped by vaccine type from 2011 through 2022. Ages 19 to 49 are shown on the left, and ages 50 to 64 are on the right. Rates of IPD caused by PCV20 and PCV21 serotypes shown in gray, PCV20, non-PCV20 serotypes shown in orange, and non-vaccine serotypes in dark blue all remained relatively stable in both age groups during the years preceding the pandemic of 2014 through 2019. And although the rates in these vaccine types did decline, as mentioned during the pandemic, they're returning to pre-pandemic rates in both age groups in 2022. Next slide. Back one more. I do want to point out that rates of IPD caused by PCV20 non-PCV21 serotypes shown in light blue and outlined here in red, even though they were relatively small, they have been creeping up in the years preceding the pandemic. And in 2022, the rates were higher in both these age groups than they were in their pre-pandemic levels. Serotypes 4 and 19F made up a large proportion of this serotype grouping, and we will continue to monitor these trends. Next slide. And here's the same graph, but here showing adults aged 65 years and older. And please note the y-axis is larger here due to the higher burden of disease. Here we see similar trends to what was observed in younger adults, with stable rates from 2014 through 2019. However, in older adults, we do not see an increase in rates of PCV20 non-PCV21 serotypes. Next slide. These graphs show the proportion of IPD by each vaccine type among adults with the pneumococcal vaccine indication in 2018 through 2022. Adults aged 19 to 64 years with a risk-based indication are shown on the left, and adults aged 85 years and older are on the right. PCV20, non-PCV21, shown on the bottom in light blue, accounted for 7 to 13% of IPD in these adult groups. PCV20 and PCV21 in gray accounted for 45 to 47%, while PCV21 non-PCV20 in orange accounted for 36 to 38%. Finally, non-vaccine types in dark blue at the top accounted for 6 to 8% of IPD. So PCV20 provides 54 to 58% serotype coverage among adults with the vaccination indication, while PCV21 provides 81 to 85% serotype coverage. Next slide. In conclusion, during the pandemic, rates of IPD declined but are now returning to pre-pandemic levels. Over 80% of adult IPD cases have a risk-based indication for vaccination. PCV21 has greater coverage of the serotypes causing IPD in adults compared with PCV20. And again, PCV20 covers 54 to 58% of IPD in adults with a vaccine indication, while PCV21 covers 81 to 84%. Next slide. And with that, I'll stop and answer any questions.
Thank you, Mr. Gierke. Are there questions for the speaker? That was really nicely illustrated.
Thank you.
Okay, well, I think we can move on to the next speaker. Dr. Self.
I'm here.
Okay, I think we've got your slides up and you can proceed.
Thank you for this invitation. I'm Wesley Self from Vanderbilt University, and I have the privilege of presenting interim results from what we call the PNEUMO study here today. This is a study sponsored by Merck, and it includes investigators at Vanderbilt, where I am, and Emory University, where we've been enrolling pneumonia patients for the last 4 years. Our contribution here is to show serotype distribution in urine antigen tests for the PCV21. Next slide. Just a little bit of background about the PNEUMO study. This is an epidemiologic study that's been ongoing since 2018. We're enrolling adults at 3 hospitals across Tennessee and Georgia who have community-acquired pneumonia. The design in the United States is to enroll prospectively patients who present to the hospital with confirmed pneumonia radiographically. And then our goals are to estimate the incidence of pneumococcal pneumonia, as well as the incidence of the serotypes in PCV15 and PCV21, which I'll refer to as V116 here. In the future, we're also going to be looking at long-term outcomes, including direct medical costs, work loss, functional loss, cognitive status, and quality of life. I'll be focused today on the prevalence of serotypes in our hospitalized community-acquired pneumonia population. Next slide. As mentioned, the enrollment period here started in September 2018. We are continuing enrollment to today. I'll focus the data presentation today on results through 2022. The enrolling sites are at Vanderbilt, which is in Nashville, Tennessee, and 2 hospitals affiliated with the Emory University System in Atlanta, Georgia. Next slide. A bit on eligibility criteria. So this is real-time prospective enrollment. These are the patients that we enroll into our surveillance program. These are adults, so age 18 and above, who are admitted to the hospital in observation or inpatient status, who have clinical evidence of pneumonia, as denoted by both an acute respiratory symptom, such as shortness of breath or cough, as well as an infectious symptom, such as leukocytosis or fever. And then all of our analyzed patients have pneumonia confirmed on either an X-ray or a CT scan by a radiologist. We do exclude some patients at the bottom of the slide. We only enroll a patient once for an episode of pneumonia. So if they're rehospitalized, they're not enrolled the second hospitalization. We only enroll community, or what used to be called healthcare-associated pneumonia. So we exclude patients who develop pneumonia in the hospital or hospital-acquired pneumonia. We are only enrolling patients who provide a urine sample, because most of our pneumococcal detection is by urine antigen tests. So those on those with end-stage renal disease and anuric are not enrolled in this particular study. And then finally, we exclude patients who have respiratory symptoms completely explained by an alternative diagnosis that's not pneumonia, such as if a person has a pulmonary embolism, otherwise meets eligibility criteria, but we can clearly attribute the symptoms to the PE. Next slide. So after we enroll these adults hospitalized with community-acquired pneumonia, they undergo systematic testing for Streptococcus pneumoniae. We collect urine. That urine is collected within 72 hours of hospital admission. And then this urine undergoes 2 sets of tests. The first one is the Bionex now commercially available pneumococcal antigen test, which we run in our research labs immediately after enrollment. And then we also send aliquots to Merck Laboratories. And then at Merck Laboratories, the urine undergoes a battery of serotype-specific urinary antigen detection assays. You can see the 30 serotypes listed here for which the urine is tested for. Notably, this contains all of the serotypes in PCV15, PCV20, and V116, except serotype 15B, which is in PCV20. Additionally, we record the results of all bacterial cultures that are obtained in the hospital for these patients, and we split those into sterile site cultures as listed and non-sterile site cultures as listed. Next slide. So this is what we've found so far. So again, this is 4 years from 2018 through 2022. Notably, that is about half of that enrollment period is before COVID-19 onset in the US, and half during the first 2 years of the COVID-19 pandemic. So during that period at 3 sites, we screened about 5,300 patients, enrolled about 3,200 patients who met eligibility criteria. And then our analytical population, you can see there is 2,917. These are pneumonia patients in the hospital from which we collected a urine sample. In terms of pneumococcal detection on the second to bottom level there, 12.1% of all of our hospitalized community-acquired pneumonia patients had pneumococcus detected. So we report a prevalence of 12.1% for pneumococcal disease among all-cause hospitalized community-acquired pneumonia adults. And then of those who have pneumococcal pneumonia, 51 of those had invasive disease and 301 had non-invasive disease. So about 85% of our cohort of pneumococcal pneumonia was non-invasive pneumococcal pneumonia. Next slide. In terms of characteristics for this cohort, I'll point out a few key features. The columns here are broken into characteristic on the far left, and then pneumococcal pneumonia. And then the third column are pneumonia patients who did not have pneumococcus detected or non-pneumococcal pneumonia, and then a p-value. A couple highlights. Age for the pneumococcal and non-pneumococcal groups are about the same, median at 60 years. Higher proportion of pneumococcal pneumonia patients were Black race at 41%. Next slide. Higher proportion in the pneumococcal group smoked and drank alcohol regularly and interacted with a young child regularly. Next slide. Higher prevalence of COPD in the pneumococcal group compared to the non-pneumococcal group, and a lower prevalence of obesity. Next slide. And then importantly, in terms of epidemiologic patterns, you can see highlighted in the blue box there, about half of the cohort was enrolled before onset of COVID-19, but 2/3 of the pneumococcal cases were enrolled before onset of COVID-19, consistent with this theme that pneumococcal incident prevalence declined during the pandemic. Next slide. In terms of positive tests for pneumococcus, here's our Venn diagram. So the SUAD is, again, that serotype-specific urinary antigen detection assays, which were run at Merck Laboratories. There were 30 serotypes in this particular set of assays. You can see 283 of the patients positive for pneumococcus of a total of 352 had a positive SUAD. And the SUAD was the only positive test in 57% of those with a pneumococcus detected. You can see Bionix now detects some, but certainly less than the SUAD tests, and then culture is far less. Next slide. In terms of what we found from the pneumococcal serotype distribution, so remember we tested for 30 serotypes in the urine. These are all urine results here. The serotypes are listed across the x-axis, and then the bars demonstrate the percentage of the 316 serotypes detected, and then the counts in the white there. So serotype 3 was the most prevalent, and it was detected in 14.6% of all serotypes with serotype 3. You can see the distribution there. Next slide. So probably the most important slide, I'll walk you through it. So what this shows is the percentage of all-cause community-acquired pneumonia patients who tested positive for specific serotypes in the different vaccines. So if you look at the table at the bottom, you can see the V116 is the 21-valent vaccine, PCV21. The listed 21 serotypes in that particular vaccine there in the second column. And then the third column shows that 9.3% of all of our hospitalized adults with community-acquired pneumonia, 9.3% of them had a serotype detected that is in V116. Similarly, for PCV20 as the second row there, notable, we did not test for serotype 15B, but in prior studies, 15B appeared to be fairly uncommon. So we tested for 19 of the 20 serotypes in PCV20. Those 19 serotypes are listed there in the second column. So PCV20, there were 6.7% of all of our pneumonia patients had a serotype in PCV20 detected. PCV15, you can see in the next row, had 5.8% of all of our community-acquired pneumonia patients had a serotype detected that's in PC15. And then the lowest row there, or the bottom row, are the 11 unique serotypes in V116 that are not in PCV15 or 20. You can see 4.1% of our patients had one of those serotypes detected. And then the plots show this same pattern by age group. So on the left is the 18 to 49-year-old age group. The middle group there is the 50 to 64-year-olds. And then on the right is the 65 plus. Same pattern with V116 having the highest prevalence in each of these age groups, followed by PCV20, PCV15, and then the last column in each of the groups shows the percentage of patients who had a serotype unique to V116, not in PCV20 or 15. And you can see in the older than 65 age group, for example, that's 3.1%. Next slide. So in conclusion, pneumococcal community-acquired pneumonia remains a major cause of adult hospitalizations. These serotype-specific urinary antigen detection assays greatly increase the detection of pneumococcus over traditional testing and seem to be critical for identifying non-invasive pneumococcal disease. And among adults hospitalized with community-acquired pneumonia in this study, about 12% had pneumococcus detected. 9.3% of patients had a pneumococcal serotype in V116, and 4.1% had a serotype unique to V116 that's not in the two currently licensed pneumococcal vaccines. The most common detected serotypes that were unique to V116 were 35B, 9N, 23A, and 23B. And with that, I think I can take questions and turn it back over. Thank you.
Thank you very much. Are there questions for Dr. Self? Dr. Daly.
Yeah, thanks so much. If you could go back to the Venn diagram for a sec, I am not very familiar with this test. And so what are the test characteristics and how do I interpret this? I guess if the test characteristics are different by serotype, that would be more influential than if they're not. But I still feel like this, I'm trying to interpret what we know about whether this was pneumococcal disease and what the serotype was based on the results of the urine test. So could you just sort of help us interpret this in the context of what we know about the test characteristics of the urine test in particular? Thank you.
Yes, I'd happy to take that. And I believe there's some colleagues from Merck on who helped develop this test who may have comments as well. So these are individual antigen tests looking for polysaccharide in the urine, similar to the set of urine antigen tests developed by Pfizer to accompany PCV13. These are developed and validated using urine from healthy adults, as well as adults with known positive blood cultures for specific serotypes of pneumococcus. So the threshold to determine a positive antigen test is serotype specific, and then that's calibrated against known positives and negatives. Now, historically, I mean, we've known, I think, that the Bionix Now urinary antigen test greatly increased pneumococcal yield compared to blood culture. And then these serotype-specific antigen tests, both with the previously developed Merck assays and now these, previously developed Pfizer assays and now these Merck assays appear to detect more cases of pneumococcal disease than both Bionix Now and culture. Though it is a good question, when we have a test that appears to have increased analytical sensitivity compared to historical criterion standards, understanding if these are false positives or true positives is critically important. I will note that kind of the distribution of serotypes by both the previously developed Pfizer test and these more recently developed Merck tests are quite similar in the literature, at least for me, giving me some more confidence that these appear to be true positives that we're picking up. But there may be other comments from those who developed this test, and I think we can circulate the publications that go through the development and validation of these SUEDs.
This is Thorsten Verge. We developed the tests here at Merck, just pretty much Dr. Serf had it covered to add on the SUED detects serotype-specific polysaccharides or the fragments thereof, whereas Bionix Now detects a different section that detects more the common polysaccharide across all pneumococcus. So they measure different things, and the polysaccharides in urine are very different from the ones that are on the bacterial surface. So for all those reasons, there's not that total overlap that you might expect theoretically. And as Dr. Serf pointed out, this type of Venn diagram distribution is very similar to other SUED tests and versus Bionix Now in the literature.
Thank you. We can take a couple more quick questions. Dr. Cotton?
Regarding the urinary antigen for Legionella, the urine antigen can be positive for many months after infection. Is that true in this setting? Thank you.
You want to take that, Thorsten, and I'm happy to add.
Yeah, so yes, urine antigen assay does remain positive for a while longer. We don't know exactly for how much longer. It's a matter of how long polysaccharides are present in the body, of course.
Yes, and these particular patients were acutely ill with pneumonia, but the point's well taken that the positive tests could linger after the acute illness.
Thank you.
Are there additional questions from the committee? Dr. Chen.
I guess two questions. One is, have you looked at the serotypes for the invasive cases, and do they seem to match up with the epi data that Mr. Gerke presented for the kind of surveillance data that have been seen nationally? And then the second question is, it looks like the enrolled patients consort-like diagram shows 51 invasive cases, and then your Venn diagram seems to indicate that there are 56 patients with culture positive. So, I guess that those might not have all been culture positive from sterile sites. They might have been non-sterile sites. So just wondering, is it 56 or 51 invasive cases?
Yes, good question. And your assumptions are correct. It's 56 positives with any positive culture, which includes some respiratory cultures that meet quality criteria. So for example, sputum cultures that meet more than 25 white cells per low-powered film. But then we had, if you go back one slide, this 51 number is correct for invasive disease, which would include positive blood cultures, synovial or CSF. Make sure that answers that question, the non-invasive versus
that
invasive.
does. And then the serotypes, were you able to analyze the subset that had invasive disease, and did it seem to reciprocate the kind of serotypes that were seen from the ABC?
Yeah, it's an excellent question, and we did do that. We have 41 patients who had a serotype identified via blood culture. So blood culture positive for Streptococcus pneumonia, and then whole genome sequencing. And of those 31, so 31 of the 41 had a serotype that is tested for in our 30 serotype set of SUAD, and 84% of those 31 patients, right? So the 31 patients who we would expect to find the same serotype in the SUAD, 84%, we did find the corresponding serotype in the urine that was found by blood culture. And then the distribution, and I can display this if helpful or send it around, but the distribution of serotypes in the invasive disease in our study do match the CDC data quite well.
Okay, I think we'll move on to the next presentation. Dr. Platt from Merck will be presenting the phase 3 clinical trial data. Dr. Platt?
Yes, can you hear me okay?
Yes, we can.
Excellent. Thank you for the opportunity. And on behalf of the V116 team, I'm going to present key results from the phase 3 clinical development program of V116, an investigational adult-specific pneumococcal conjugate vaccine. Next slide, please. I'm sorry, it seems like there's a delay. I don't see it on the webcast. I'll keep going. I will present the rationale for development and an overview of the clinical development program, followed by key immunogenicity results in study-specific populations and an integrated summary of safety. Next slide, please. Starting on the left side of the slide, the direct impact of vaccination of children is substantial. Though, as shown on the right, more modest decreases are observed in adults due to indirect impact. The burden of disease in adults is now higher than it is in children, with approximately 24 cases per 100,000 in adults, compared to 7 cases in children. Next slide, please. Even with the indirect impact from childhood vaccination, there remains an unmet medical need in adults. V116 is a population-specific vaccine proposed to meet this need and is intended to complement pediatric immunization programs. Next slide, please. V116 contains 21 pneumococcal serotypes conjugated to CRM197, formulated without an adjuvant, supplied as a single-dose 0.5 ml pre-filled syringe. In the US in 2019, the serotypes in V116 accounted for approximately 85% of IPD, with the 8 unique serotypes accounting for approximately 30% of IPD in adults 65 years of age and older. V116 is currently under priority review by the FDA for the prevention of IPD and pneumonia in adults 18 years of age and older, with a target action date of June 17, 2024. Next slide, please. The serotypes in V116 are responsible for the majority of residual IPD in adults, accounting for approximately 83% and 85% of IPD cases in adults 50 to 64 and 65 years of age and older, respectively. Next slide, please. I'll move on to provide an overview of the Phase 3 clinical development program. Next slide. The program is comprised of 7 studies, 6 in adults and 1 in pediatrics, and focused on enrolling participants at risk for pneumococcal disease. The pediatric study is evaluating children 2 through 18 years with increased risk conditions who have already completed a primary pneumococcal vaccine regimen. Next slide, please. The 4 studies in the V116 BLA submission represent a broad, diverse patient population. The studies enrolled participants from 21 countries representing 5 continents. A third of the participants were 65 years of age and older, had 1 or more chronic risk condition, and 18% had previously received a pneumococcal vaccine. Next slide. Functional OPA responses supported the primary immunogenicity objectives. Additional OPA and IgG endpoints supported the secondary objectives. The primary safety objective is the same for all of the Phase 3 studies and included the evaluation of solicited injection site and systemic events and vaccine-related SAEs. Next slide, please. So to start, Protocol 3 is a Phase 3 randomized double-blind study designed to evaluate the safety, tolerability, and immunogenicity of V116 in pneumococcal vaccine-naive adults. Next slide. Over 2,600 participants were enrolled in parallel cohorts. In Cohort 1, participants 50 years of age and older were stratified by age and randomized 1-to-1 to receive either V116 or PCV20. In Cohort 2, participants 18 to 49 years of age were randomized 2-to-1 to receive V116 or PCV20. Immunogenicity samples were drawn at baseline and 30 days post-vaccination, and an electronic vaccine report card was used to record solicited events through day 5 post-vaccination. SAEs were reported through the duration of the study. Next slide, please. The primary immunogenicity objectives were evaluated by cohort with statistical testing for non-inferiority and superiority in Cohort 1. And in Cohort 2, immunobridging in adults 18 to 49 years to adults 50 to 64 years was evaluated. As already mentioned, the primary safety objective is the same for all of the Phase 3 studies. Next slide, please. In each cohort, baseline characteristics were balanced between the treatment groups. In Cohort 1, approximately 50% of the participants were 65 years of age and older. And though not shown, specifically in the US, there was focused enrollment on groups historically underrepresented in clinical studies. And in Cohort 1 in the US, approximately 18% of participants were Black or African American. Next slide. Moving on to the immunogenicity results. In adults 50 years of age and older, V116 is non-inferior to PCV20 for all 10 of the common serotypes, based on the lower bound of the 95% confidence interval of the OPA geometric mean titer, or GMT, ratio being greater than 0.5. This is shown as the dashed vertical line on the forest plot. Next slide, please. In adults 50 years of age and older, V116 is superior to PCV20 for 10 of 11 serotypes unique to V116. This is based on the lower bound of the 95% confidence interval of the OPA-GMT ratio being greater than 2.0, again shown as the dashed vertical line on the forest plot. For serotype 15C, the lower bound is 1.77 and did not meet the pre-specified criteria, likely based on cross-reactive immune responses to serotype 15B in the comparator. Next slide, please. In adults 50 years of age and older, so staying with cohort 1, V116 is superior to PCV20 for 10 of 11 serotypes. This is based on the percentage of participants with a 4-fold rise or greater in OPA responses, where the lower bound of the 95% confidence interval of the difference between the groups had to be greater than 10 percentage points. And again, for serotype 15C, 83.4% of participants in the V116 group had a 4-fold rise in OPA responses. This is the second highest 4-fold rise of the unique serotypes. Next slide, please. V116 elicits robust antibody responses to serotype 15B. These responses are cross-reactive to serotype 15C, which is included in the vaccine. Next slide, please. Moving on to cohort 2. Immune responses in V116 in participants 18 to 49 years of age, immunobridged to participants 50 to 64 years of age. Again, based on the GMT ratio, where the lower bound of the confidence interval was greater than 0.5 for all serotypes in the vaccine. And overall, in Protocol 3, IgG immune responses were consistent with the OPA responses across the endpoints assessed. Next slide, please. I'll move on to Protocol 6, which evaluated the safety, tolerability, and immunogenicity in pneumococcal vaccine-experienced adults 50 years of age and older. Next slide. Approximately 700 participants were enrolled into one of 3 cohorts based on the pneumococcal vaccine they received at least 1 year prior to enrollment. In cohort 1, participants who were previously vaccinated with PPSV23 were randomized in a 2-to-1 ratio to receive either V116 or PCV15. In cohort 2, participants who were previously vaccinated with PCV13 were randomized in a 2-to-1 ratio to receive either 116 or PPSV23. And cohort 3. These are participants who were previously vaccinated with an other pneumococcal vaccine or vaccines, and they were allocated to receive open label V116. Okay, next slide, please. The primary immunogenicity objective was to evaluate the serotype-specific OPA responses 30 days after vaccination, and again, safety is consistent across the phase 3 studies. Next slide, please. Enrollment is balanced in each cohort and reflects the pneumococcal vaccination history, where there is a higher percentage of participants with a longer time since last vaccination in cohort 1, reflecting likely the longer time that PPSV23 has been in the recommendations. Next slide, please. So in cohort 1, for common serotypes on the left, immune responses are generally comparable between participants who received 116 and PCV15, and higher for serotypes unique to V116 on the right. Next slide. In cohort 2, again, for common serotypes on the left, immune responses are generally comparable between participants who received V116 and PPSV23, and higher for serotypes unique to V116 on the right. Next slide. We'll finish this one with cohort 3, where V116 is immunogenic in individuals who previously received an other pneumococcal vaccine or vaccines. And as shown on the bottom left, the immune responses to serotype 3 were robust across the 3 cohorts. Next slide, please. We will review a summary of an integrated analysis of safety. Next slide, please. So V116 is well tolerated in adults 18 years of age and older with a safety profile comparable to currently licensed pneumococcal vaccines. The integrated summary of safety includes participants from 4 phase 3 studies in participants who received V116 and the control group, which includes participants who received an active comparator, either PCV15, PCV20, or PPSV23. Frequencies of AEs were comparable across the categories of adverse events, vaccine-related adverse events, and SAEs. There were 2 vaccine-related SAEs across the 4 studies. No deaths were assessed to be vaccine-related. Next slide, please. The frequencies of solicited adverse events were comparable in the V116 and comparator groups. The majority of solicited events were mild or moderate in intensity and less than or equal to 3 days in duration. Next slide, please. We'll provide a brief summary of the immune responses in 3 supportive studies evaluating V116 in adults living with HIV, V116 when administered concomitantly with quadrivalent influenza vaccine, and the lot consistency study of V116. Next slide, please. In adults 18 years of age and older living with HIV, V116 elicits comparable immune responses to PCV15 plus PPSV23 on the left, and higher immune responses for unique serotypes on the right. Next slide, please. In participants 50 years of age and older, including both vaccine-naive and vaccine-experienced adults, V116 elicits robust immune responses when administered concomitantly with influenza vaccine, meeting non-inferiority for the concomitant group and the sequential group for 20 of 21 serotypes, based on the lower bound of the OPA-GMT ratio being greater than 0.5. And QIV administered concomitantly is non-inferior to QIV administered sequentially for 3 of the 4 strains. This is based on the lower bound of the confidence interval of the HAI titers being greater than 0.67. Next slide, please. And in the lot consistency study, immune responses were equivalent across 3 manufacturing lots. Next slide, please. We'll move on to a summary and conclusions on the next slide, please. In adults 18 years of age and older who are pneumococcal vaccine naive and vaccine experienced with and without risk conditions, V116 elicits robust immune responses to all 21 serotypes contained in the vaccine. V116 is non-inferior to PCV20 for all common serotypes and superior to PCV20 for 10 of the 11 serotypes unique to V116. V116 is immunogenic in pneumococcal vaccine-experienced adults, regardless of the prior vaccine received, and is immunogenic when administered concomitantly with inactivated influenza vaccine. V116 is well tolerated with a safety profile generally comparable to currently licensed pneumococcal vaccines. To conclude, V116 is the first adult-specific PCV with the potential for broad public health impact through the prevention of invasive disease and pneumonia due to strep pneumoniae. Next slide, please. On behalf of the V116 study team, I thank you for the opportunity to present this data.
Thank you, Dr. Platt, for that concise presentation. We can take a few questions from the committee, if there are any. Dr. Brooks.
Yes, thank you for that. Excuse me, for the presentation. Which one of the flu strains were you non-inferior to, or did you not, get the desired titers?
Sure. If you want to show backup slide 43, we can show the plot of the HAI titers. I don't know how easy it is to go there. Oh, there you go. I think I saw it pop up. No? Let's see if we can.
Yeah, but I don't know. I can't tell which one.
It's H3N2, yeah. And the lower bound of the 95% confidence interval was exactly 0.67. And that was the threshold for meeting the criteria.
Oh, okay. Thank you.
Yeah, thank you for the question.
Are there other questions? Okay, well, maybe if there's additional questions later, Dr. Platt, perhaps you can stay on in case something else comes up. So we'll move on to the presentation on post-licensure PCV20 safety data with Dr. Morrow starting us off.
Good afternoon. Okay, so I'll be describing the post-licensure safety surveillance of 20-valent pneumococcal conjugate vaccine among U.S. adults in the vaccine adverse event reporting system. The next slide, please. So what you see is my disclaimer. The next slide. So these are the topics that I'll be discussing. So I'll provide first a background on pre-licensure safety of the 20-valent pneumococcal conjugate vaccine. I'll then describe the adverse events following PCV20 reported to bears. And I'll also describe some adverse events of a special interest, such as Guillain-Barré syndrome. And at the end, I'll provide a summary. The next slide, please. As a background, in pre-licensure clinical trials of PCV20, this vaccine was found to be very safe. The serious adverse events were balanced among vaccinees and the placebo. And there were no cases of Guillain-Barré syndrome observed. The next slide, please. So on June 2021, PCV20 was approved by the Food and Drug Administration, and in October of 2021, ACIP recommended this vaccine for use in adults age 65 years or over, as well as adults 19 to 64 years of age. The next slide. So the objectives of this review were to describe the safety profile of reports submitted to bears after PCV20 in adults. The next slide. Well, this slide has been shown before in the morning today. I'll just point out that bears has a number of limitations. One important limitation is that it's not designed to assess for causality. The next slide, please. So we searched the bears database for reports of PCV20 during the period going from October 21st, 2021 through December 31st, 2023 in adults aged 19 years or older. We reviewed serious reports and medical records, and we also looked for reports of Guillain-Barré syndrome and applied the Brighton criteria definition. The next slide, please. We also calculated reporting rates using doses distributed of PCV20. And FDA conducted empirical Bayesian data mining, which is used to detect disproportional reporting. The next slide, please. So this first slide shows the characteristics of the reports that after PCV20 that bears has received. And you'll note that the total number of reports received were 2,393, And most of these were in adults 19 years of age or older, with 1,976 reports. And about 6% of the reports were serious. The next slide. So this slide shows the most common signs and symptoms in reports to bears following PCV20 in adults ages 19 to 64 years. On the left, you see the most common adverse events in non-serious reports, and many of these are, as you can see, are injection site or systemic reactions. On the right, you see the serious reports, and the most common adverse events are systemic reactions. The next slide. So here we see the most common signs and symptoms in reports to bears following PCV20 in persons aged 60 years or over. And similar to the previous slide, on the left, you see the most common adverse events for non-serious reports, and most conditions are local or systemic reactions. On the right, you see the most common adverse events for serious reports, and you'll note that there are some systemic reactions, but there's also Guillain-Barré syndrome as the fourth most common condition being reported. The next slide, please. So empirical Bayesian data mining found disproportionate reporting for the preferred term Guillain-Barré syndrome among the serious reports. The EB05 was equal to 3.6. If the EB05 is over 2, then that's considered to be an alert or a signal. The next slide, please. And so what we did was to review these reports of Guillain-Barré syndrome. And this slide summarizes the information from these reports. So on the right, you'll see that there were 20 reports of Guillain-Barré syndrome after PCV20. We reviewed some of these, and we excluded, based upon review, 5 reports. There are 4 that remain still under review. We are waiting for medical records. And so we were left with 11 reports of verified GBS. On the left, you see some characteristics of these reports, some more information. So the median age was 66 years with a range of 46 to 79 years. The median time to onset was 14 days with a range of 0 to 23 days. There were 4 males, 7 females. And you'll know that also that there were other vaccines were given in 5 of 11 reports. That's during the same visit. And you can see the specific vaccines in the slide. The next slide. So the reporting rate for GBS after PCV20 was 0.5 cases per million doses distributed, or 0.9 cases per 100,000 person years, which is below the background rate. But we should keep in mind that doses distributed, it's kind of difficult to interpret. It shouldn't be taken as doses administered, because we don't. We don't really know how many of these doses of vaccine have been administered to persons, and also to what age group. We don't have the information on age for doses distributed. The next slide, please. So in summary, bears received 1,976 reports after PCV20 in adults during the study period. Most of the reports, or 94%, were non-serious. The most commonly reported adverse events were injection site and systemic reactions, which is consistent with findings from pre-licensure studies. The next slide, please. Disproportionate reporting for Guillain-Barré syndrome was identified to bears after PCV20. Potential safety signals detected in bears need to be evaluated in more robust population-based active systems, such as the Vaccine Safety Data Link or the Center for Medicaid Services. Separate studies are currently in progress in the VSD and in the CMS to assess PCV20 vaccine safety. And you'll be hearing very soon a study that describes the findings on PCV20 safety from CMS. And CDC and FDA will continue to monitor the safety of PCV20. And I think that's the last. And I'd like to acknowledge and thank these organizations and the people from these organizations for their contribution in this project. Thank you.
Thank you very much, Dr. Morrow. I think we'll go on to Dr. Forshi's presentation and then take questions after the second presentation. Dr. Forshi?
Thank you very much. My name is Rich Forshi. I'm the Deputy Director of the Office of Biostatistics and Pharmacovigilance in FDA CBER. Next slide, please. Standard disclaimer slide. The study I'm about to describe was funded by the US FDA. We worked with our colleagues at CMS and their contractor Acumen to conduct the study, and there are no conflicts of interest to disclose. Next slide, please. I'm going to describe our sequential monitoring, active surveillance for the PCV20 vaccine. We pre-specified a dozen outcomes listed here that we have been following, and it included Guillain-Barré syndrome, or GBS, that was just discussed in Dr. Morrow's presentation. Next slide, please. This slide summarizes our study design for this analysis. What I'll be presenting today is the concurrent comparator cohort design that we've been using for our near real-time sequential analysis. We're using Medicare data for this, and specifically Medicare fee-for-service for people who aged into Medicare and received one dose of, for this presentation, PCV20. Pardon me. And I already mentioned the health outcomes. Next slide, please. I apologize, I'm recovering from a cold. So for our statistical analysis here, we used a Bayesian approach to estimate the association between exposure to PCV20 and the outcomes that we listed. The high-level overview of the Bayesian approach is that we began by assuming that we knew very little about the association between the exposure to PCV20 and the outcomes. This is called a diffuse prior in Bayesian language. And then as evidence accumulated, we would update every month for a new distribution called a posterior distribution, showing what we had learned about the likely association. We established two thresholds for a safety signal, what we called a weak signal at a 95% credible interval that exceeded 1, or a strong signal if the 98% credible interval exceeded 1. Next slide, please. As was mentioned earlier, we've seen much more uptake of PCV20 than PCV15. At the November 30th data cut for this study, we had more than 2.8 million doses of PCV20 in our database, but only 53,000 for PCV15. So we've only done sequential analysis for PCV20. Next slide, please. I'm not going to go into detail on this slide, but this provides the descriptive statistics for the PCV20 vaccinees. Next slide, please. And this slide provides the outcome counts and incidence rates for the PCV20 vaccinated population. Please note that in some cases we had to suppress the cell size because of small numbers. So when you see a dash in one of the cell sizes, that means we suppressed it in order to protect any possible personal information from being inadvertently disclosed. This slide also includes the risk window and comparison window that we used in the analysis. One thing that I would note is that for some of the outcomes, we have a relatively small number of outcomes observed. and specifically for GBS, we only have 29 outcomes observed so far, which is good news for public health, but it means that our estimates are not terribly precise at this point. Next slide, please. This slide is a tabular summary of the results to date. And again, this data cut is November 30th, 2023. We have not identified any statistically significant elevated risks. I will point out that for GBS, which is about 3/4 of the way down this table, the incidence rate ratio is 2.19 with relatively large confidence intervals. And I'll talk more about that in future slides. Next slide, please. I'm about to move into a graphic description of how the distributions have evolved over time as we got each new month of data added to the analysis. I'm going to start by going through an example of the myocarditis pericarditis graph before going to the small multiples graph on the next page. So what we're seeing on this is how the posterior distribution evolves over time as more and more information accumulated from our data. A few key things to look at on the graph. The first is each graph contains a dashed red line for the incident rate ratio of 1.0, which is the null effect line. There is a black dot on each one of the distributions that represents the median of the posterior distribution. And the gray distribution shows the estimated posterior distribution after each update from each additional month of data. Next slide, please. This shows the evolution of the posterior distributions for all 12 of the outcomes. I'll draw your attention first to the upper left-hand corner for acute myocardial infarction. Note how narrow the posterior distributions are really from the first month for acute myocardial infarction, and that it is clustered very close to the null effect line of 1.0. What this indicates is that because of the amount of data that has accumulated so far, we would have to see a very large divergence from the pattern we've seen to this date to see this distribution move much from the 1.0 line. In contrast, look at the next slide to the right, which is the anaphylaxis outcome, where we had far fewer outcomes. This is also roughly centered around the null effect line of 1.0, but it is much wider, indicating that we still have a great deal of uncertainty regarding the true association between PCV20 and the risk of anaphylaxis. Because of the previous presentation about GBS, I'll draw your attention to the third row, second column for the GBS. And there you can see that we have a great deal of uncertainty. The most recent point estimate was a little over 2, but it still crosses the null effect line. Next slide, please. So in summary, the incidence rates post PCV20, the IRs for myocarditis, pericarditis, anaphylaxis, GBS, and immune thrombocytopenia are all less than 100 cases per 100,000 person years. In terms of signal detection, we do not have any statistically significant risk elevation that we have identified so far. However, we will continue to monitor and evaluate these health outcomes. Next slide. A few limitations for this kind of sequential monitoring. Because we're using Bayesian methods, Just because we don't have a statistically significant result today doesn't mean that we won't have one in the future, depending on the evidence that comes in as we continue to monitor. Statistical signals may appear or disappear from month to month, depending on the evidence that we see. What I've presented today, these events have not been chart confirmed, and for some of the results, the positive predictive value are likely to be low. For example, in recent studies, we found the PPV for Bell's palsy was just over 12%, and the PPV for ITP was only about 4%. This is an early analysis, an early sequential analysis. Residual confounding may still exist because we haven't been able to adjust for many potential variables. And there's a large uncertainty of incidence rate ratios for certain outcomes, including GPS. When we have a small number of events, we'll have wide credible intervals. Next slide, please. Our active monitoring and the sequential monitoring will continue monthly. We also had pre-planned an end of surveillance analysis using self-controlled case series method for each outcome where we have sufficient sample size and where we had identified a potential risk from the sequential analysis. Next slide, please. Now I've been asked to briefly summarize the evidence from both of these safety talks. So for PCV20, there was no GBS signal in the clinical trials. As Dr. Moreau described, we do have a GBS signal for PCV20 in theirs. We currently do not have a GBS signal in our Medicare sequential monitoring, but that is ongoing. There's still significant uncertainty because of the small number of cases observed. And there are limitations in both theirs and the Medicare studies. I just talked about some of the limitations in our Medicare studies. And as Dr. Moreau pointed out, theirs is not designed to establish causal associations between vaccines and health outcomes. Next slide. None of this work is possible without a large team. Here I've listed the people who assisted me at FDA CBER and the large team at Acumen and our longstanding collaboration with the Centers for Medicare and Medicaid Services. Next slide, and I believe I am finished. Yeah, these are supplemental slides, so thank you very much.
Thank you, Dr. Forshee. So we've had another excellent example of the collaborative approach to safety between CDC and FDA in this pair of presentations. Are there any questions for either of our speakers? Okay, there'll be an additional opportunity for questions later on in the session. So if you want to come up with some questions, if there's questions later, I think we can get to them. Dr. Kobayashi, do you want to move on to the policy questions and work group interpretations?
Yes, thank you very much. Good afternoon. I'm Iwako Kobayashi, and on behalf of the pneumococcal vaccines work group, I will present preliminary work group interpretations and ETR of ETR and next steps. As a reminder, here are the 3 policy questions that are being considered by the work group. 1, should PCV21 be recommended for U.S. adults aged 19 years and older who currently have a recommendation to receive a PCV? The comparison is current vaccine recommendations. So for adults who have not received a PCV, either 1 dose of PCV15 followed by PPSV23 or 1 dose of PCV20, and for adults who have received a PCV but have not completed the recommended series, either 1 dose of PCV20 or 1 or more doses of PPSV23. 2, should PCV21 be recommended for U.S. adults aged 50 to 64 years who currently do not have a risk-based pneumococcal vaccine indication? 3, should PCV21 be recommended for U.S. adults aged 19 to 49 years who currently do not have a risk-based pneumococcal vaccine indication? For both of these groups, the comparison is no vaccine. Please note that questions 2 and 3 imply a new age-based recommendation for these age groups, as Dr. Lair mentioned earlier, since adults in these age groups who currently have risk-based indications are already covered in question 1. The ETR framework consists of the 7 domains shown here. And today I will go over the workgroup interpretations of public health problem, benefits and harms, and equity. First is public health problem. Is pneumococcal disease of public health importance? Prior to the COVID-19 pandemic, there were more than 100,000 non-invasive pneumococcal pneumonia hospitalizations and more than 30,000 invasive pneumococcal disease or IPD cases, with 3,000 IPD deaths every year among adults of all age groups. Risk of disease and severe outcomes is higher among older adults and adults with certain risk conditions. In a study of adults aged 65 years and older hospitalized with community-acquired pneumonia, which was not limited to pneumococcal pneumonia, over 1/3 of adults died within 1 year. And more than 80% of IPD cases occurred among adults who currently have risk-based vaccine indications. You've seen this figure earlier, which shows changes in IPD incidence by year by age group in the United States, and the blue dotted line shows the trend for adults 65 years and older who currently have the highest disease incidence across all age groups. IPD incidence reached a historically low level early in the COVID-19 pandemic, but is increasing toward pre-COVID levels. Around the same time, new pneumococcal conjugate vaccines, PCV15 and PCV20, were recommended for both adults and children. So disease caused by additional pneumococcal serotypes contained in these new vaccines is expected to decrease due to both direct effects from vaccinating adults and indirect effects from vaccinating children. However, 30 to 40% of adult IPD cases outlined in purple in the figure are caused by serotypes that are not contained in currently available pneumococcal vaccines. And the additional serotypes contained in PCV21, shown in green, cover most of them. Is pneumococcal disease of public health importance? For adults who are currently recommended to receive a PCV, whom I will refer to as group 1, the work group interpretation was yes. Some members chose probably yes due to the decrease in pneumococcal disease burden compared to the past, and despite the increase in disease incidence in recent years, the trend is expected to stabilize at pre-pandemic levels. For adults 50 to 64 years who currently don't have a risk-based indication, whom I will refer to as group 2, the workgroup interpretation was probably yes, since pneumococcal disease incidence in this age group overall is lower compared with adults aged 65 and older. For adults aged 19 to 49 years who currently do not have a risk-based vaccine indication, whom I will refer to as group 3, the workgroup members' opinions were split. The most common responses were no, probably no, and don't know. And no and probably no combined were selected by half of the members. The primary reason expressed by the workgroup members is because of the even lower disease incidence in this age group compared with adults aged 50 to 64 years. Next is benefits and harms. How substantial are the desirable anticipated effects of PCV21 vaccination? How substantial are the undesirable anticipated effects of PCV21 vaccination? Do the desirable effects of PCV21 vaccination outweigh the undesirable effects? What is the overall certainty of evidence for the critical outcomes? To assess the benefits of PCV21 use, the outcomes deemed critical were vaccine type IPD, vaccine type non-bacterial pneumococcal pneumonia, and vaccine type pneumococcal deaths. However, there are currently no studies assessing PCV21 against these clinical outcomes. Therefore, PCV21 immunogenicity studies were used as evidence for grade. Regarding outcomes related to harms, evidence on serious adverse events was available and reviewed. Details of the methods are provided in the supplementary slides. Data from 6 phase 2 or 3 clinical trials were included for grade, which included 5 that provided immunogenicity data and 6 that provided safety data. And in the next few slides, I will present the summary for Group 1, since data from all 6 studies shown here were considered for this group. Here's the summary of grade for evidence on benefits. In a phase 2 trial compared with PPSV23, PCV21 met non-inferiority criteria for all 9 shared serotypes and superiority criteria for all 12 unique serotypes. Compared with PCV20, PCV21 met non-inferiority criteria for all 10 shared serotypes and superiority criteria for 10 of 11 unique serotypes. Compared with PCV15, immune responses for PCV21 were numerically higher for 1 to 4 of 6 shared serotypes and all unique serotypes. And a statistical comparison was not performed for this comparison. The certainty of evidence was determined to be moderate since these are immunogenicity data only without established correlates of protection. Here's the summary of grade for the evidence on harms. Across 6 studies considered for this assessment, 57 serious adverse events following PCV21 administration were reported. 2 were considered to be vaccine-related, which were bronchospasm and injection site cellulitis, and Guillain-Barré syndrome was not reported among the trial participants. The certainty of evidence was determined to be moderate due to few events of the outcome reported resulting in imprecision. How substantial are the desirable anticipated effects of PCV21 vaccination? For Group 1, the workgroup interpretation was split between moderate and large. For Group 2, the workgroup interpretation was split between small and moderate. And for Group 3, the workgroup interpretation was split between minimal and small. How substantial are the undesirable anticipated effects of PCV21 vaccination? The majority of workgroup members selected minimal for all 3 groups. Do the desirable effects of PCV21 vaccination outweigh the undesirable anticipated effects? For groups 1 and 2, the majority of the workgroup members believed that PCV21 use was favored. For Group 3, the workgroup opinion varied, although favors PCV21 use and favors current recommendation, which is no vaccine, were the most common responses selected, with a slight preference for favors current. In the next few slides, I will summarize the workgroup discussions. Members who were in favor of PCV21 use shared that based on available data, there are no concerns about the risks outweighing the benefits of PCV21 vaccination. And for adults who are currently recommended to receive a PCV, PCV21 provides broader serotype coverage than any of the currently recommended vaccines. Some saw benefits of PCV21 administration by lowering the age-based recommendation to age 50 years, which is reflected in the second policy question, because we can expect a more robust immune response by administering PCV21 before age 65 years and before a portion of that population develops an immunocompromising condition. Some expressed concerns or uncertainties about lowering the age-based recommendation, especially to age 19 years, which is reflected in the third policy question. The degree of benefits for adults who currently don't have vaccine recommendations is uncertain. Epidemiology does not support expanding the vaccine indications to younger adults without a risk-based indication. Younger adults in their early 20s would have received a PCV as a child, so the benefits of PCV administration to this group are uncertain. We could miss the opportunity to provide protection against disease later in life if we lower the age-based recommendation. There are limited data on duration of protection or protection against disease from multiple PCV doses in adults. Some members expressed the need to review cost-effectiveness analysis data. Next is equity. What would be the impact of recommending PCV21 use for adults on health equity? Racial disparities in IPD incidence have existed. However, white non-Hispanic adults who generally have lower disease incidence have higher vaccine coverage compared with other race or ethnicity groups. After PCV13 use in children, disparities in IPD incidence in adults caused by serotypes contained in PCV13 decreased. This is shown in the figure, which shows IPD incidence in Black and white adults for all serotypes, PCV13 serotypes, and non-PCV13 serotypes by year and age group. Most of the remaining disparities are due to non-PCV13 type disease. However, increase in serotype 4, a serotype included in currently available pneumococcal vaccines, but not in PCV21, has been reported in certain groups. Increase in serotype 4 IPD cases has been reported in Western United States, and the incidence was 100 to 300 times higher in people experiencing homelessness compared to those who were not. In Alaska, IPD incidence due to serotype 4 increased 88-fold in 2019-2020 compared with 2011 through 2018, and the increase was notable, especially among Alaska Native population. What would be the impact of recommending PCV21 use for adults on health equity? For group 1, the workgroup interpretation was probably increased equity. Additional serotype coverage by PCV21 is expected to reduce racial disparities in remaining pneumococcal disease burden. However, for adults who have already received a PCV, recommending a second PCV dose to complete the recommended vaccine series might magnify the underlying disparities in vaccine coverage. The workgroup interpretation was also probably increased for groups 2 and 3, and the workgroup interpretation considered the possible implications of lowering the age-based vaccine recommendation. Some workgroup members believed that lowering the age threshold for the age-based recommendation is expected to improve vaccine coverage in adults who currently have risk-based vaccine indications in these groups, and therefore be more equitable. This is a summary of the workgroup's interpretations of the ETR domains we reviewed today, and the domains with different interpretations between groups are highlighted in dark blue. Okay, now I will present workgroup next steps. The workgroup will review findings from both published and unpublished cost-effectiveness analyses on PCV21 use among adults, review evidence and discuss interpretations of remaining ETR domains, values, acceptability, resource use, and feasibility, and draft policy options for PCV21 use in US adults for consideration by the committee and for a potential vote at the June ACIP meeting. This will include considerations for expanding the current risk-based vaccine indications to include adults with chronic kidney disease who are not on maintenance dialysis, and I will describe this further in the next few slides. For adults, those with chronic renal failure or nephrotic syndrome have indications for pneumococcal vaccination. That is around the middle of this table here. When PCV20 was recommended for children in June 2023, the risk-based indication was expanded to include those with chronic kidney disease who are not on dialysis or who do not have nephrotic syndrome, and that is highlighted in red in the table. The workgroup has been discussing whether evidence supports the change in adults as well. Members who are in favor of expanding the indications consider that pneumococcal disease risk is increased in earlier CKD stages before being on dialysis, and the expansion would allow them to receive the vaccine when the immune response is more robust. Those who are concerned or cautious about expanding the indications consider that, unlike children, CKD is more common in adults. Inclusion of earlier stages, such as CKD stage 3A, could potentially result in expanding the risk-based indication to a much larger proportion of adults, and therefore would like to see a cost-benefit analysis to help support the discussion. Lastly, here are the questions for the committee. Considering additional pneumococcal vaccines for adults who are additional vaccines are currently under investigation and may be approved in the near future, and dynamic changes in pneumococcal disease incidence are anticipated post-COVID-19 and with increased uptake in PCV15 or PCV20 in children and adults. Do you have any feedback on the policy questions being considered by the work group? What additional data would be helpful to inform the discussions on PCV21 use in adults? And what additional data would be needed to help inform the discussions on expanding the risk-based indications to include adults with chronic kidney disease? I'd like to thank the following groups and individuals for their contributions, as otherwise the work would not have been possible. Thank you very much, and I'd be happy to take any questions.
Thank you, Dr. Kobayashi. Can we put the slide back with the questions for the committee? Okay, thank you. Yeah, let's leave that up. So there's been a lot of information presented, and the work group has asked for any feedback on the policy questions being considered by the work group, what additional data would be helpful, and are there thoughts about an expanded risk-based indication to include adults with chronic kidney disease, which is the second time we've heard about chronic kidney disease today. So any thoughts from the committee members or our ex officios on any of these questions, or for that matter, the other presentations in the session? Dr. Zanias.
Yes, do you have any more data on adults experiencing homelessness in Western United States and adults in Alaska? As I would worry about creating a disparity by having a recommendation that might put them at higher risk.
Thank you for that question. By additional questions, were you asking about why they're
actually additional data, but yes, I'm also curious as to why they're more at risk, or why we see this 88-fold increase in IPD in that population.
Yes, thank you very much for that question. So I can start with the people experiencing homelessness. So there have been, in addition to what we showed through the surveillance data, there have been clusters of serotype 4 IPD among people experiencing homelessness. And we don't know why exactly serotype 4 specifically, but there are some hypotheses. You know, there may be some low-level circulation in the community, and then these populations somehow seem to be susceptible, or there might be introduction of a new strain of serotype 4 introduced to certain pockets and then therefore impacting these people experiencing homelessness disproportionately. So there are still uncertainties, but there are definitely reports, not just limited to the US, about clusters of serotype 4 invasive pneumococcal disease among people experiencing homelessness. And then in terms of the Alaska Native population, so this is also, so I'll say that these are also populations that tend to have higher disease incidence in general, pneumococcal disease, and they tend to have some unique characteristics in serotype distribution. The serotype 4, again, probably similar hypotheses apply. And there are certain other serotypes that have been seen or causing clusters in these populations. So I don't have the exact answer to why specifically, but you know, unfortunately, the serotype 4 is seen to disproportionately affect these populations.
Thank you.
Dr. Cotton.
I know the work group was split, but I'd like to say that for the age 19 to 49 population, I would hold on vaccinating them until we have more robust data and more of a clear need. I think there's a lot of vaccine fatigue out there, and let's focus on the higher yield populations. It is, the data that's been shown is quite impressive in general, but yeah, let's not overwhelm people. Maybe we should focus on the vaccines that they really need that they're not getting. Thank you.
Thank you for that comment.
Dr. Daly?
Yeah, a couple comments. First is, in terms of the policy questions, I think these are a good approach. I think it makes sense, at least to me, that these are the policy questions. And then I had a similar reaction to the 19 to 49 age group in terms of, at this point, based on what I've seen so far, I'd be reluctant to extend to that unless there's a strong case made there. In terms of the 50 to 64, I'm trying to get a sense about the burden and the disparities, and I know some of that's there, but it would be great to get a better sense about sort of, cases averted in that age group, and trade that off with durability of the immune response in terms of whether we feel like folks vaccinated in that age range are going to have a durable response, or will they need revaccination when they're a little bit older, those kind of things. And then the last question is a much more pragmatic one, and this one's actually probably at somebody like Dr. Lair. Dr. Lair, if I could have you put on your practicing physician hat rather than your chair hat or your ACIP member hat. I just have these concerns that there's complexity, and then that creates barriers, and then that creates lower coverage. So as someone who sees kids and adults, if you chose to have PCV21, would you just need 2 vaccines in the office, two pneumococcal conjugate vaccines in the office, or is that getting ahead of ourselves?
Thank you. Yes, I would just perceive 2 vaccines in the office. Thank you.
Dr. Long.
I know that's not the question we are addressing today, 21 versus 20 and the others, but there are a few risks with 21. It looks like it covers more serotypes, they're better matched to adults, et cetera, but it gives up multiple serotypes, and we already know one of the ones it gives up is 4, so would Alaska have to be carved out? And is what's going on in Alaska with 4, which is really quite striking and not completely well understood, is that going to happen to the lower 49? Oh, I guess Alaska is Hawaii is lower. Yeah, not usually called the lower. We usually call these the lower 48. From Alaska, we did. So that's a bit of a risk. The other thing is, Dr. Kobayashi will remember and tell me if I've remembered this correctly or incorrectly. As I remember, non-inferiority and superiority aside, it looked as if 20 was had little lower geometric mean antibody responses than, for instance, 13, for the things that were included in 13. 15 looked a little higher. So now we have 21 that is not non-inferior, but is a little lower than 20. So the question is that correct?
I don't know if our representative from Merck is here who might want to provide specific answers, but it does vary by serotype. It wasn't, for example, when we looked more recently, PCV20 versus PCV13 in children, we did see a kind of a trend of numerically lower immune responses overall in the shared serotypes between PCV13 and PCV20. But that was not what we observed PCV20 when PCV20 was compared to PCV21. It wasn't uniformly numerically lower, but I don't know if anybody from Merck would like to add on to that.
So for 21 versus...
Yeah, sorry, this is Heather Platt from Merck. I'm happy to respond.
Who's this?
We looked at the common serotypes, so the serotypes that are in both PCV20 and PCV21, and we used the accepted non-inferiority pre-specified criterion of the lower bound being greater than 0.5. Also acknowledging that there is a concern of looking at the immunogenicity as serotypes are added to conjugate vaccines. What we observed is that we met the non-inferiority criteria of the lower bound being greater than 0.5, but if you look at the slide, when you go back to it, you can see that the lower bound of the 95% confidence interval for the ratio is actually greater than 0.67 for all of the common serotypes. I think this should give us confidence in the overall vaccine performance when we look at the endpoints, not just for the OPA responses, but the IgG responses were also consistent. I hope that helps.
May I just continue my thought?
Yes.
When we don't know the architectural plan, you know, what is protection against pneumococcal serotype at any of the serotypes, but we see, you know, although none was non-inferior, the fact that all but one was lower, statistically significantly not crossing 1, and that was the same way with 20 versus some others. At what point, if you change a board here and you change a board here, this board isn't different from this board and this board isn't different from this board, but is this board different from the original architectural plan? Without efficacy or effectiveness data, it gives me pause to certainly think that because there are more serotypes included, that necessarily means that's going to be better efficacy, and especially a little concerned about losing serotype 4. Thank you. There's not much you can do before we get to a policy question, however, so I don't have a suggestion on more data.
Yeah. I'll just take one additional moment to respond, and thank you for showing the slide. I agree with you. We conduct our phase 3 studies based on evaluation of immune responses, but we also acknowledge that we need effectiveness or efficacy data. We are planning to evaluate the effectiveness of V116 in a real-world study, and we will share more details with the CDC work group, and hopefully we'll be able to share more details with the larger group shortly.
Thank you, Dr. Platt. Are there other questions from the committee or from our ex officios? Dr. Lair.
This is more a comment, and it helped me to have the meningitis and the pneumococcal work groups back to back. The incidence is dramatically different. Meningitis is literally a 1 in a million disease. The pneumococcal, even for the lowest group on Dr. earlier slide, was maybe 50 in a million. And for over 65, it was 170 in a million. And that just sort of reminds me that sometimes when we're focusing so much on individual vaccines, we should sort of take the bigger picture and see, maybe compare one vaccine versus another in incidence and importance. So that was just what was striking me today. Thank you.
Thank you for that comment, Dr. Lair. Yeah, Dr. Bargle.
Just to follow up to what Dr. Daly said, and maybe this is a question for Dr. Kobayashi or Dr. Lair. And Dr. Daly highlighted the complexity and how complexity are barriers. It seems like the market took care, the clinicians took care of PCV20 versus 15, and they decided which one was better for their practice. Is there any possibility that, or has a working group considered the removing the strains from these recommendations? Because Dr. Lair really highlighted how this is going to get so much more complex. We've got PCV21, then 24, then 25, then 31 coming, and trying to make recommendations for each of those and what the added value is. And is there a way to envision a set of recommendations that don't try to compare the individual types versus a larger policies, broader policies?
Dr. Kobayashi, I can't imagine that you have not been thinking about that, and there may have been some discussion in the work group about what you think the future of these recommendations looks like with so many vaccines under development. Would you like to say anything to that?
Yes, thank you for that comment. That is part of the reason why, we posed a question of, considering that all these vaccines are in the pipeline, do you have any feedback for the policy questions that we're currently considering? And we are fully aware of the complexities of the recommendations that currently exist for pneumococcal vaccination. I think, ideally everybody is looking for a very simplified approach to pneumococcal vaccination and harmonize across age groups. I think that's what we'd like to strive for.
Until we had the preferential recommendation for the high dose, the recombinant, and the adjuvanted flu vaccines for people 65 and older, we had many different influenza vaccines that were all recommended. They weren't all licensed for use in every age group, but they were all recommended, and they differed somewhat in their characteristics. We provided information on those differences, and to what degree people actually use that information to make decisions about what they used, I can't say, but it does feel like we're sort of moving in that direction, maybe. Other questions or thoughts from anyone in the group? Dr. Lair, would you like to have the last word? Okay. Okay, well, I think we may have concluded this discussion. We were considering going straight on to the next session. Would that be acceptable, or do y'all need a quick break? I think we'll go straight on. I think the team for the next session is here. Dr. Collins? Can we get Dr. Collins' slides ready to go, and Dr. Lair's? So thanks to all of our speakers in the pneumococcal session. Interesting and important topics. Thank you to all our presenters, and as always to the committee for good discussion and questions. We'll be moving on to our final session of the meeting with the discussion of the use of combined diphtheria and tetanus toxoids in acellular pertussis, inactivated Haemophilus influenza Type B Conjugate, and Hepatitis B vaccine, otherwise known as Vaxelis, among American Indian and Native Alaska populations. So, Dr. Lair, do you want to set up the session for us?
Thank you, Dr. Wharton. I'm not going to try to repeat what you just said, and I'm simply going to call it Vaxelis. This is going to be a very interesting presentation because we often have questions and we don't always get the answers, and this is one of the situations where we actually have a study that answered one of our important questions. So I actually enjoy this session very much. Next slide, please. I'd like to thank everyone for their time and work on this meningeal Hib work group. Next slide. So for background purposes, there's a preferential recommendation for American Indian and Alaska Native infants to use PEDVAX Hib. Historically, Hib meningitis peaked at an earlier age among AI-AN infants, and PEDVAX Hib provided a protective antibody response after the first dose and provided additional protection. So we have a preferential recommendation which has been there for many years. Interestingly enough, Vaxelis uses the same vaccine, but in a lower dose than in PEDVAX Hib. And so it did not fit into the preferential recommendation because we did not know whether the lower dose would actually provide the same benefits that PEDVAX Hib. So next slide. The policy question is, should Vaxelis be included with PEDVAX Hib in the preferential recommendation for American Indian and Alaska Native infants? Next slide. So the work group had this question, and we reviewed the epidemiology of the invasive Hib disease. More importantly, we reviewed the clinical trial data on a post-dose 1 immunogenicity of Vaxelis versus PEDVAX Hib. And we've been working on drafting a recommended policy based on grade and ETR, which will be coming up in the near future. Next slide. So today's agenda, we're going to go over all the work that we've done so far, including the background of Hib disease and vaccination among AI-AN populations, and then a very wonderful study where they compared PEDVax-Hib versus Vaxelis to see if the benefits would hold up. And then we'll go over the work group considerations at the end. Back to you, Dr. Wharton.
Thank you, Dr. Lair. Next up is Dr. Jennifer Collins, who will be providing background on invasive Hib disease and vaccination among American Indian and Alaska Native populations.
Good afternoon. Next slide. Next slide. Haemophilus influenzae are gram-negative bacilli. When first discovered in the late 1890s, they were originally thought to be the cause of influenza, hence the name. Often abbreviated as H-flu or just HI, infections can range from mild to severe invasive disease. Next slide. Haemophilus influenzae are classified as encapsulated or unencapsulated. Encapsulated or typable HI have a polysaccharide capsule with 6 serotypes, lettered A through F, based on the particular polysaccharide antigens expressed. Unencapsulated HI do not have a capsule. They cannot be serotyped and therefore are also referred to as non-typable. Next slide. Haemophilus influenzae serotype B, or Hib, is the most virulent and is the only type preventable through vaccination. Before the introduction of effective vaccines, Hib was the leading cause of bacterial meningitis and other invasive bacterial disease in the United States, primarily among children aged less than 5 years. Next slide. Risk factors for invasive Hib disease in the pre-vaccine era are shown here and include demographic factors such as male sex, American Indian, Alaska Native, and Black races, social factors such as household crowding and large household size, and the immunocompromising conditions listed here. Next slide. The most common clinical syndromes of invasive Hib disease in the post-vaccine era are bacteremic pneumonia, bacteremia without a focus, and meningitis. Epiglottitis was also one of the most common syndromes in the pre-vaccine era. Next slide. As shown in this graph of incidence over time from 1980 through 2012, the estimated incidence of invasive Hib disease in children aged less than 5 years decreased dramatically after introduction of Hib vaccines, shown in blue. Next slide. Hib polysaccharide conjugate vaccines remain the primary prevention strategy for Hib. These vaccines consist of capsular polysaccharide, abbreviated PRP, conjugated to carrier proteins, either tetanus toxoid, abbreviated PRPT, or outer membrane protein of meningococcal serogroup B, abbreviated PRP-OMP. They are highly immunogenic via activation of T-cell dependent immunity. 95% of infants develop protective antibody levels after a primary series. However, they offer no cross-protection against non-B serotypes or non-typable HI. The estimated clinical efficacy against Hib is 95 to 100%, and invasive Hib disease is uncommon in children who are fully vaccinated. Next slide. Current Hib vaccines licensed and available in the United States are shown here. They include 3 monovalent vaccines and 2 combination vaccines. Notably, the monovalent vaccine PRP-OMP, trade name PEDVax-Hib, is preferentially recommended for American Indian and Alaska Native children, which I will discuss more next. Next slide. This preferential recommendation relates to the fact that invasive Hib disease disproportionately affects American Indian and Alaska Native populations, especially young children. Next slide. Let's go back to the pre-vaccine era again for some context. This graph shows the incidence of invasive Hib disease among U.S. children aged less than 5 years from 1980 through 2012. The incidence of Hib disease among U.S. children declined more than 99% following introduction of Hib vaccines into the childhood immunization schedule. Next slide. However, expanding the y-axis by 10-fold is necessary. Next slide. To capture the incidence of invasive Hib disease among American Indian and Alaska Native children aged less than 5 years in the pre-vaccine era, which was up to 280 cases per 100,000 and more than 10 times higher than the incidence among U.S. children aged less than 5 years overall. Next slide. Fortunately, the incidence of Hib disease among American Indian and Alaska Native children aged less than 5 years declined more than 98% with Hib vaccination, as shown on this bar graph with pre-vaccine era incidence on the left and recent post-vaccine era incidence on the right. Next slide. Yet among children aged less than 5 years, the incidence of invasive H. flu disease remains substantially higher among American Indian and Alaska Native children, shown in purple, compared with non-Native children, shown in gray. Next slide. Focusing on Hib, you can see American Indian and Alaska Native children still have a 31-fold higher incidence of invasive Hib disease than non-Native children. Next slide. In the pre-vaccine era, the incidence of Hib meningitis peaked at a younger age among American Indian and Alaska Native populations than among the general U.S. population. This graph shows the incidence of Hib meningitis by age from 1971 through 1977, with Alaska Native children in red, Navajo Nation children in orange, and children from the general U.S. population in blue. Among Alaska Native and Navajo Nation children, the peak was not only higher, but also occurred earlier, at age 4 through 5 months. Among children in the general U.S. population, the peak was lower and occurred later, at age 6 through 9 months. Next slide. This table shows characteristics of invasive Hib disease cases among American Indian children aged less than 5 years reported to CDC's active bacterial core surveillance system from 2003 through 2023. The median age was 12 months. 31% of cases occurred among unvaccinated children. The most common syndromes were meningitis, 45% of cases, followed by pneumonia, 41% of cases. Next slide. Now we'll discuss Hib vaccination among American Indian and Alaska Native infants. Next slide. PEDVAX Hib, or PRP-OMP, is preferentially recommended for American Indian and Alaska Native infants. The ACIP recommendations shown on this slide predate the licensure of Vaxelis, and note that vaccination with a 2-dose primary series of a Hib vaccine that contains PRP-OMP, that is now PEDVAX Hib, is preferred for American Indian and Alaska Native infants to provide earlier protection because this vaccine produces a protective antibody response after the first dose. A booster dose, dose 3 in this case, of Hib vaccine is then recommended at age 12 through 15 months. For the booster dose, there is no preferred vaccine formulation. Next slide. As noted, PRP-OMP provides earlier protection. This graph summarizes antibody responses to PRP-OMP, shown in blue, to PRP-T, shown in orange, and to other Hib vaccines that are no longer available in the United States, shown in gray and black. Antibody levels are shown before vaccination and after dose 1, 2, and 3 of the primary series, given at ages 2, 4, and 6 months, respectively. As demonstrated with the blue bars on the graph, PRP-OMP produces a protective antibody response after the first dose, based on the correlate of short-term protection of 0.15 microgram per ml. Thus, the preferential recommendation for PEDVAX Hib aims to address the earlier peak in meningitis among American Indian and Alaska Native infants from the pre-vaccine era. However, final antibody titers are higher with PRP-T, as shown with the orange bars in the figure. Note that this data shows 3 primary series doses of PRP-OMP, with only a moderate increase in antibody levels after the second and third dose. Hence, the current primary series of PRP-OMP is only 2 doses. Next slide. Notably, the incidence of invasive Hib disease in Alaska Native populations increased in the late 1990s amid vaccine policy changes. This graph from Alaska shows the incidence of invasive Hib disease per 100,000 among Native children aged less than 5 years, shown in black, and non-Native children aged less than 5 years, shown in gray, from 1980 through 2004. Next slide. Here is the same graph, now superimposed with the timeline of Hib vaccine policy changes in Alaska for additional context. The incidence of invasive Hib disease was declining before universal Hib vaccination began in 1991. Universal Hib vaccination began first with the Hib oligosaccharide CRM-197 vaccine, abbreviated HBOC, in January. This was changed to PRP-OMP in July of 1991. In January of 1996, a combination vaccine with diphtheria, tetanus, pertussis, and HBOC replaced PRP-OMP in order to decrease the number of injections at each visit. In October 1997, following an increase in cases of invasive Hib disease, an official change was made to PRP-OMP for dose 1, followed by HBOC for doses 2 through 4, though some tribal facilities had made this change as early as July of 1996. This change was supported by studies demonstrating that the highest antibody concentrations were obtained by initiating the Hib primary series with 1 dose of PRP-OMP and concluding with 2 doses of either PRP-T or HBOC. In 2001, a change was made back to PRP-OMP for all Hib doses. Next slide. This chart shows vaccine status among children aged less than 10 years with invasive Hib disease in Alaska from 1991 through 2004. During 1996 through 2000, when vaccine policy changes had been made to include HBOC, a greater proportion of cases occurred among Alaska Native children, represented by the white circles, occurred among partially immunized children, represented by the gray boxes, and were considered true vaccine failures, represented by the black boxes. Next slide. Vaccine administration errors may have contributed to some cases when both PRP-OMP and HBOC were used. From October 1997 through December of 2000, 14 cases occurred in Alaska Native children aged less than 5 years. 3 of those children, or 21%, had inadvertently received HBOC for their first and only dose of Hib vaccine. Next slide. Increases in Hib disease in Alaska during 1996 through 2000 were ultimately attributed to the use of HBOC, which did not achieve short-term protective antibody concentrations until the 3rd dose, and low rates of on-time immunization. Next slide. Recent vaccine coverage data from the National Immunization Survey Child are shown here. Estimated vaccination coverage with a Hib full series by age 24 months among American Indian or Alaska Native children ranged from 67.5% to 77% for birth cohorts born during 2016 through 2020. Next slide. In 2019 through 2020, American Indian or Alaska Native children were less likely than white children to have received the Hib full series by age 24 months. An estimated 68.7% of American Indian or Alaska Native children had received the Hib full series, which was significantly lower than the estimated 80.8% for white children. Next slide. Now we'll discuss Vaxelis. Next slide. Vaxelis, a hexavalent combination vaccine that protects against diphtheria, tetanus, pertussis, polio, Hib, and hepatitis B, is a newer vaccine in the United States. It was licensed in December 2018, and ACIP voted to include it in the Vaccines for Children, or VFC program, in June of 2019. Per the manufacturer, more than 6.2 million doses have been distributed in the United States as of Q4 of 2013. Next slide. Vaxelis does not currently have a preferential recommendation for American Indian or Alaska Native infants because post-dose 1 immunogenicity data were not previously available. And it is not equivalent to PDVax-Hib because it contains a lower dose of PRP-OMP. PDVax-Hib has 7.5 micrograms of PRP and 3 micrograms versus 3 micrograms in Vaxelis. And PVax-Hib has 125 micrograms of OMP versus 50 micrograms in Vaxelis. Next slide. In phase 3 clinical trials, Hib antibody responses after the 3-dose primary series were non-inferior to licensed comparator vaccines in 2 studies. Data from 1 study are shown here, with the Vaxelis group represented by orange circles and the control group represented by blue triangles. The data points on the left represent the percentage with a PRP level greater than 1 microgram per milliliter, the putative correlate of long-term protection. And those on the right represent the percentage with a PRP level greater than 0.15 microgram per milliliter, the putative correlate of short-term protection. Antibody responses in the Vaxelis group met non-inferiority criteria. Next slide. Regarding safety of Vaxelis, in pre-licensure clinical trials, the safety profile was consistent with that of licensed comparator vaccines, except for a higher rate of fever than with DTaP IPV-Hib. However, rates of fever-related medical adverse events were similar between groups. A post-licensure analysis of data from the Vaccine Adverse Event Reporting System, VAERS, from June 2019 through June 2023 did not identify new or unexpected safety issues. Next slide. Vaxelis protects against 6 infections with fewer injections. This table shows 3 options for how either Vaxelis or PVax-Hib can be used with other vaccines to complete the routine childhood immunization series for the 6 infections covered by Vaxelis. Note this is not all immunizations in the childhood series. Option 1 uses Vaxelis for a total of 5 injections. Option 2 uses PVax-Hib and the combination vaccine Pediarix for a total of 7 injections. Option 3 uses the individual component vaccines for a total of 12 injections. Next slide. The proposed policy question is, should Vaxelis be included with PVax-Hib in the preferential recommendation for American Indian and Alaska Native infants? Next slide. I would like to acknowledge the many people listed here whose valuable contributions made this presentation possible. Next slide. Thank you. I'm happy to take any questions.
Thank you very much, Dr. Collins, for that excellent overview. Do we have any questions for Dr. Collins? Well, if not, Dr. Chen.
I think I asked this before also in the work group, but I wanted to understand the what was leading to the lower uptake of American Indians and Alaskan Natives to have to be fully vaccinated against Hib, 68.7% versus 80% for white non-Hispanic. And is it that the perception of multiple vaccines at that visit was perhaps leading to that? And then again, would a multivalent vaccine, Vaxelis, improve that, perhaps that perception and maybe increase the uptake? Because ultimately we want increased uptake as the end goal.
I don't know if you'd like to go back to that slide, it's slide 29 that had that data. I'll say we don't know the answer as to why there's a disparity, and the disparity is rather new in the past several years. Historically, the rates of immunization have been similar between those 2 racial groups, and I don't have a great understanding as to why.
Are there other questions? Dr. Brooks?
Fine question. HBOC, is that the capsular antibody vaccine?
It was an oligosaccharide conjugated vaccine, but it was one of the earlier conjugate vaccines.
Oh, okay.
It was not the polysaccharide vaccine.
Okay.
Okay, not seeing any other questions, I think we can move on to Dr. Hammett's presentation, and we can ask Dr. Collins additional questions after that if there are any. Dr. Hammett, are you ready?
Yes, thank you. Good afternoon. I'm Laura Hammett, and I lead the infectious disease team at the Center for Indigenous Health at the Johns Hopkins Bloomberg School of Public Health. And I'm joining today from Southwest Colorado near the Navajo Nation. And on behalf of the study team in Navajo Nation and Anchorage, Alaska, and Baltimore, I'm honored to be presenting the results of the HibVax study, which assessed the immunogenicity of Hib vaccines in American Indian and Alaska Native infants. Next slide, please. This study was supported by a research grant from the Investigator-Initiated Studies program of Merck, Sharp, and Dohm, acting on behalf of a joint venture with Sanofi, known as MSP Vaccine Company. And after the ACIP vote to recommend Vaxelis several years ago for use in US infants, but to withhold a preferential recommendation for use in AIAN infants, and knowing the benefits of combination vaccines, we submitted a proposal through the Merck Investigator-Initiated Studies program and are grateful for their support for this study looking at the post-dose 1 immunogenicity of Vaxelis in this population. My disclosures are research grants to my institution from AstraZeneca, Merck, Pfizer, CDC, and NIH. And the findings and conclusions in this presentation are those of the authors and do not necessarily represent the official position of the Indian Health Service or the Centers for Disease Control and Prevention. Next slide, please. Dr. Collins provided an excellent overview, so I'll just briefly mention the considerations underlying the preferential recommendation for Hib vaccines that use the PRP-OMP conjugate for AIAN infants. In the pre-vaccine era, AIAN infants experienced invasive Hib disease at a younger age compared to the general US population, so vaccines that could provide protection early in life were critical. Next slide, please. A second reason for this recommendation is that a single dose of PRP-OMP Hib conjugate vaccine at 2 months of age was highly immunogenic, as Dr. Collins showed, and was also shown to be protective against invasive disease. On the right is a table from the pivotal phase 3 randomized clinical trial of the PRP-OMP vaccine, which was conducted in the Navajo Nation. The red rectangle highlights the excellent efficacy against invasive Hib disease following the first dose. And based on the immunogenicity and efficacy data, PRP-OMP became the de facto preferred Hib vaccine for AIAN children following licensure in late 1990. Next slide, please. As was also mentioned by Dr. Collins, the importance of the PRP-OMP conjugate was underscored in the mid-1990s when Hib disease reemerged in Alaska Native infants following a switch from PRP-OMP Hib vaccine to HBOC, which used a different conjugate and had the trade name of Hib titer. After exclusive use of PRP-OMP Hib vaccine was re-implemented, sustained reductions in Hib disease were observed in Alaska Native infants. Next slide, please. PRP-OMP Hib vaccine was introduced in Navajo Nation following the phase 3 trial as a 2-dose primary series with a booster given at 12 to 15 months. And here you see disease incidence in children on the children less than 5 on the y-axis and calendar year on the x-axis. The incidence in Navajo Nation is shown in the red line compared to the general US in the blue line. Prior to the availability of Hib vaccine, disease incidence was 4-fold higher in Navajo Nation. And widespread use of the PRP-OMP Hib vaccine fortunately led to rapid and sustained reductions in disease, and the average number of invasive Hib cases in children under 5 in the Navajo Nation declined from roughly 19 per year to fewer than 2 per year. You can see that disparities in disease incidence persisted, but fortunately, Navajo Nation hasn't experienced a case of invasive Hib in a child less than 5 since 2016. Next slide, please. This slide shows the epidemiological characteristics of the 25 invasive Hib cases that have occurred in the past 2 decades in Navajo Nation and White Mountain Apache tribal lands in the Southwest US. Similar to what Dr. Collins showed for the US data, the median age of cases has gone up, is now 14 months, with a range of 2 to 52 months. Meningitis was diagnosed in 28% of cases and pneumonia in 40% of cases. And other cases were bacteremia, sepsis, and osteomyelitis. The vaccination history of cases is shown in the figure. And on the left-hand side of that figure, you can see that only 4 cases occurred in unvaccinated infants who ranged in age from 2 months to 11 months. In the middle, we see that 7 cases were in infants or children who are up to date for age on their Hib vaccine, and they ranged in age from 4 months to 12 months. Most of the cases, 14 in total, were in fully vaccinated children, meaning they had completed the primary series and a booster dose. And so this highlights, I think, a potential vulnerability between the time that the primary series is completed at 4 months of age until the receipt of a booster dose at 12 to 15 months of age, and also suggests that protection does wane some after the booster dose. Next slide, please. In this context that we sought to assess the potential for use of Vaxelis in AIAN infants. And select characteristics of the 2 vaccines are shown on this slide. The single antigen vaccine PVax-Hib is on the left in green compared to the hexavalent vaccine Vaxelis on the right. As has been mentioned, Vaxelis is not preferentially recommended for AIAN infants. It is a PRP-OMP conjugate. Both of the vaccines use the Hib capsular antigen, the polyribosyl ribitol phosphate, or PRP, conjugated to OMP, the outer membrane protein of Neisseria meningitidis. But PVax-Hib contains 7.5 micrograms of the PRP antigen compared to 3 micrograms in Vaxelis. PVax-Hib uses a 2-dose primary series compared to a 3-dose primary series for Vaxelis. And PVax-Hib has been shown to elicit protective antibody concentrations post-dose 1, but the post-dose 1 immunogenicity of Vaxelis is unknown. We know that advantages of combination vaccines include fewer shots, fewer missed doses, and a lower administrative burden. And that led us to try to replace those question marks in the bottom row there with data that could inform a policy decision and potentially optimize Hib protection for AIAN children. Next slide, please. Our primary objective was to answer the question posed here. Do antibody levels in AIAN infants meet non-inferiority criteria 30 days after dose 1 of Vaxelis compared to PVax-Hib? We pre-specified that Vaxelis would be considered non-inferior if the ratio of the GMCs in the Vaxelis group relative to the PVax-Hib group was greater than 0.67. Next slide, please. The HibVax study is a phase 4 prospective open-label randomized controlled trial. Study visits were aligned with routine well-child checks. Study day 1, which is highlighted in the red rectangle, was at approximately 2 months of age. And following informed consent, children underwent a physical exam, parents completed a questionnaire, a baseline blood sample was collected. Children were then randomized to either the PVax-Hib group or the Vaxelis group and received their first dose of study vaccine along with their other routine infant immunizations. Next slide, please. This study obviously compared 2 licensed vaccines with well-characterized safety profiles, and we did not collect reactogenicity data, but we did monitor for serious adverse events from the time of enrollment through the final study visit. Next slide, please. Blood samples were collected at 4 time points, at baseline, and then 30 days post-dose 1, which was our primary outcome. Again, at the 6-month well-child check, which was 60 days post-dose 2, and at the final study visit, which was 30 days post-dose 3 of Vaxelis and approximately 90 days after the completion of the PVax-Hib primary series for infants in that arm. Next slide, please. Eligible infants were those who were American Indian Alaska Native, born at 35 or more weeks of gestation, who were aged between 6 to 12 weeks, and whose parents provided written informed consent. We excluded infants who'd already received any of their routine infant vaccines other than the birth dose Hep B, those who had a history of receipt of blood or antibody products, those who were immunocompromised, those with an those with an allergy to any vaccine component or latex. And for those with an acute febrile illness, we deferred enrollment until the illness was resolved. Next slide, please. Anti-Hib IgG antibody levels were measured by a commercially available ELISA assay by the team at the CDC Arctic Investigations Program in Anchorage. Geometric mean concentrations were assessed using constrained longitudinal data analysis, which assumes that groups have an equal anti-Hib GMC at baseline based on the randomized study design. And this analysis also allows participants who are not able to contribute data at all the time points to contribute data where data are available. For this, remaining slides, we're presenting the results for all evaluable participants complying with the procedures and intervals between primary doses as defined in the protocol. Next slide, please. Enrollment began in January of 2022 at 5 sites, Anchorage, Alaska, shown in the upper map, and 4 sites in the Navajo Nation, which is shown in red on the lower map. The Navajo Nation sites were Chinle, Arizona, Fort Defiance, Arizona, Gallup, New Mexico, and Shiprock, New Mexico. All study visits were completed by October 2023. We had a target sample size of 330 participants based on our pre-specified non-inferiority objective, and our final enrollment was 333 participants. Next slide, please. Retention at each of the study visits is shown here, along with the number for which an evaluable serum sample was obtained and the number in the according to protocol cohort. Overall, the study had nearly 90% retention through the final visit. And the time point for the primary outcome is outlined in the red rectangle. Next slide, please. Here we see the participant characteristics by vaccine group. The groups were comparable in terms of age at dose 1, with a median age of 56 days in the PVax-Hib group and 60 days in the Vaxelis group. The proportion of participants who were male was 45% in the PVax-Hib group and 50% in the Vaxelis group. Randomization between groups was balanced within a site, and across the sites, enrollment was lowest in Anchorage and highest in Fort Defiance. Next slide, please. Over the course of the study, 25 serious adverse events were reported in 21 participants. 3 of the PVax-Hib recipients had 2 SAEs, and 1 Vaxelis recipient had 2 SAEs. None of the SAEs were considered related to study vaccination. The most common SAE in 21 of the cases was hospitalization for acute respiratory infection. And as we've heard in other presentations in this meeting, last winter saw extensive circulation of numerous respiratory viruses. The occurrence of ARI hospitalizations in clinical trial participants for this study is consistent with published rates in the population. Next slide, please. The results for the primary outcome are shown here. And according to protocol cohort, the Hib antibody concentrations at 30 days post-dose 1 were extremely similar. In the top row, you see the observed geometric mean concentrations in each group, 0.39 in the PVax-Hib group and 0.41 in the Vaxelis group. The results from the constrained longitudinal data analysis are shown in the row below and are nearly identical. These results indicate that both vaccines are producing similarly strong immune responses after the first dose. And the ratio of the Vaxelis to PVax-Hib GMCs was 1.03 with a confidence interval of 0.75 to 1.41. The pre-specified non-inferiority criterion was therefore met based on the lower bound of the 95% confidence interval, around the ratio being greater than 0.67. Next slide, please. The primary outcome results are shown here graphically. Anti-Hib IgG geometric mean concentration is shown on the y-axis and steady day is on the x-axis. Data from both groups were pooled at day 1 as shown in the yellow marker, and at day 31, 1 month post the first dose, antibody GMCs in the PVax-Hib group shown in the green marker and the Vaxelis group shown in the red marker were nearly identical. The horizontal dash lines on the figure correspond to the putative correlates of short-term protection of 0.15 micrograms per mil and long-term protection of 1 microgram per mil, shown near the top of the graph. Next slide, please. Here we see the antibody data for the 2 additional time points, day 121, or approximately 6 months of age, and day 151, or approximately 7 months of age. Both groups are well above the putative long-term correlate of protection at these time points. At day 121, we see that the GMCs in the PEDVAX, Hib, and Vaxelis groups are similar with overlapping confidence intervals. At day 151, we see that the GMCs are higher in the Vaxelis recipients shown in red. And this makes sense given that those infants received a 3-dose primary series, whereas the PEDVAX Hib recipients had a 2-dose primary series and therefore likely had peak antibody levels around 5 months of age, which would have corresponded to study day 90. Next slide, please. The proportion of participants with anti-Hib antibody concentrations at or above the short-term correlative protection, 0.15 micrograms per mil, was similar between groups at all time points. Over 90% of infants in both groups were above this threshold at day 121 and day 151. Next slide, please. The proportion of participants with antibody at or above the putative correlate of long-term protection, 1 microgram per mil, was similar between groups at the first 3 time points. At day 151, which was the final study visit, 84% of Vaxelis recipients were above this threshold compared to 72% of PEDVAX Hib recipients, which was a statistically significant difference. Next slide, please. The proportion of participants with a 4-fold rise in anti-Hib antibody concentration is shown here. And this was similar between groups, comparing both groups between baseline and each of the subsequent time points. Next slide, please. This study only followed participants through 7 months of age, so we're unable to evaluate longer-term antibody persistence. I think encouragingly at that final visit at approximately 7 months of age, over 90% of participants had antibody levels above the putative correlate for short-term protection. And I think it's notable that the proportion of participants with antibody levels above the putative correlate of long-term protection, as well as the antibody GMCs, were higher in the Vaxelis group at the final study visit, which may be a potential advantage of a 3-dose primary series. Next slide, please. This I think could be advantageous given that the median age of Hib disease in AIA in children is higher now and durable protection is needed. We would expect, based on where the antibody levels were at 7 months, that protection should hopefully be in place through the time of the booster dose. The current strategy for a booster dose is at 12 to 15 months of age. And here at IHS and tribal health facilities in the Southwest, this is generally slated for the 12-month well-child check. Data from previous studies suggest that booster doses following a primary series of Vaxelis are immunogenic. Notably, a heterologous booster, meaning a PRP conjugated to a carrier protein other than OMP, such as PRP conjugated to tetanus toxoid, may provide stronger and more durable protection than a homologous booster. Next slide, please. And these are data from a pre-licensure study of Vaxelis that included a cohort of American Indian infants. The post-booster GMCs are shown in the very bottom row outlined in red. And children who received a primary series of Vaxelis followed by a booster with PRPT had significantly higher post-booster GMCs of 55.4 compared to 20.9 in children who had received a primary series of PRPT followed by a booster with the same conjugate. So these data, I think, are reassuring that booster doses following a primary series of Vaxelis are immunogenic in American Indian children, and also suggest that there may be opportunities to further optimize protection against Hib with consideration of heterologous booster doses. Next slide, please. So in conclusion, post-dose 1, anti-Hib GMCs following Vaxelis met the pre-specified criteria for non-inferiority, including Vaxelis among the vaccines with a preferential recommendation for AIA in children would expand the available options for this population. We didn't do a formal qualitative assessment of acceptability, but anecdotally, parents of study participants were strongly supportive of combination vaccines as a way to reduce the number of shots that infants receive. And as people who do clinical trials will be familiar with, we had some parents who, only wanted to be in the trial if we could guarantee that the child would be in the Vaxelis group, which of course we could not. But we've also heard regularly from providers who would like to be able to offer this vaccine to their AIAN patients. Next slide, please. I'd like to wrap up just by expressing my gratitude for the study participants and their families, first and foremost. There's a long history of research abuses in marginalized populations, including Native Americans, and we're really grateful for the trust that families place in us to do this work to help improve health in their communities. I want to thank the various IRBs that guided and oversaw this work, the Indian Health Service and the tribal health facilities where the study was done, the CDC Arctic Investigations Program for collaboration and laboratory testing, and the study team in Alaska, the Southwest, and Baltimore. Thank you.
Thank you very much, Dr. Hammett. That was great. Are there any questions for Dr. Hammett about this presentation? It's very nice seeing this data gap that we had filled. Dr. Lair.
I would just like to thank you so much for this study. There was a data gap. You answered a clinical question, and your information will likely inform our decision-making, which will probably help patients, not only patient care, but also patient comfort. So I think this is a great study. Thank you.
Dr. Clark, would you like to make a comment or ask a question?
Yes, thank you, Dr. Wharton. I appreciate the opportunity and really want to express my gratitude both to Dr. Collins and Dr. Hammett for the information that they presented, which obviously has a profound impact on the Alaska Native and American Indian service population. For context, I'm a practicing pediatrician. I'm also the Chief Medical Officer for the Alaska Area Native Health Service. And I've had a chance to talk with my colleagues within Alaska and in the lower 48 of this topic. And just wanted to go through a few considerations, at least from the IHS perspective, which may be a little bit of a summary of the information that we've just had presented to us. Certainly as an immunogenicity study in our high-risk population, there are some limitations, as well as, of course, the fact that it's a small study size and duration. That notwithstanding, the demonstrated non-inferiority in comparison with Vaxelis is certainly something that is encouraging. There's always a question about the generalizability of these types of small studies, particularly looking at a small number of tribal communities. We have a saying in Indian country, if you know one tribal community, you know one tribal community, which I think holds true also for, clinical research. That having been said, we oftentimes don't have the advantage of fully generalizable studies in this context. So that's a common issue. Getting back to Dr. Chen's earlier comments, while there are multiple variables that impact both vaccine access and vaccine acceptance in Indian country, collectively, I think there's agreement in IHS among the provider community in working with our tribal partners that having a multivalent vaccine option compared to monovalent vaccines is likely to increase vaccine coverage rates. So I think that's an important consideration. And then, of course, in this situation, we have to also balance the question with regard to post-first dose vaccine immunogenicity, which, I think to some extent this study addresses, but also balance that against the potential durability of protection post-dose 3, which, as Dr. Hammett very eloquently pointed out, is an important consideration given that a substantial number of invasive HIV disease cases in Indian country are occurring in that older age group, even among fully vaccinated children. So that having been said, based on the available evidence from an IHS perspective, we support ACIP's consideration of a preferential recommendation for Vaxelis and American Indian Alaska Native infants. And we would certainly expect there to continue to be active bacterial surveillance for invasive Hib disease post-implementation if the ACIP chooses to take that approach. Thank you.
Thank you very much, Dr. Clark. Other comments or questions? Dr. Long.
It probably is for Dr. Collins. I'm trying to figure out the disease in fully immunized, average age 14 months children. And I guess you could be up to date and not have received the indicated 12 to 15 month booster. Was that the case for most of those children, or had some of them had their boosters and still got invasive disease? And then I have a little follow-up question.
Okay, so for your first question, we need to delve and clean the data to sort of sort out what precise vaccines the children in ABCs have received to sort that out, but it is sort of top of mind, and we're planning to look at it for the evidence to recommendation framework. I mean, we know that even if they received PVax-Hib, it's a 2-dose series, and historical studies demonstrated that vaccine titers, although they rose quickly after the first dose, they also waned rather quickly compared to other Hib vaccines. And so I think a main hypothesis is that it's sort of waning immunity from only a 2-dose primary series that's known to wane before sort of the booster dose is given.
Yeah, that could be it. Or it is possible that I was surprised, you know, being old enough to have taken care of so many children with Haemophilus disease, 60 cases of meningitis a year at St. Christopher's in North Philadelphia in the 1980s, early 80s. Unbelievable. There wasn't that much pneumonia. It occurred, and there was effusions, et cetera. So I wonder if this 14-month group, the older, fully vaccinated, older than a year, were predominantly pneumonia, and if maybe vaccine doesn't prevent pneumonia as extremely well as it does meningitis and pyogenic arthritis and the other ones.
That's a good point. I haven't stratified the syndromes by age group yet. I think another point, and probably a likely contributor to the residual burden of disease, are sort of ongoing disparities in social determinants of health and things like indoor air quality, sort of to your point earlier during the pneumococcal session, that could predispose to pneumonias. If we have Laura's slides up, when we go to the work group considerations, I can pull up a slide sort of comparing American Indian children to other children, but I can also just read it to you. So 43% of American Indian children had pneumonia compared to 18% of children who are not American Indian.
It was skewed in that older age group. And remind me that they're all serotyped and Type B?
Yes, the tables I presented to you are only Hib, correct.
Thank you, Dr. Long. Other questions or Dr. Daly?
Yeah, quick question for Dr. Hammett. Can you just remind us what else those children received, what other vaccines they received at the same time, and whether pneumococcal titers were evaluated? Thanks.
Thanks, Dr. Daly, for the question. So they did receive their routine pediatric immunization. So most of the clinics are using Pediarix, and then obviously rotavirus orally, and then PCV. At the time of the study, it was a sort of happening over the transition period from PCV13 to PCV15. We didn't evaluate titers. Co-administration had been evaluated previously in the pre-licensure Vaxelis studies. So we didn't do that as part of this study.
Any other questions for Dr. Hammett? Okay, Dr. Collins, would you like to proceed to the work group considerations?
Sure. Good afternoon again. Next slide. Once again, the proposed policy question is, should Vaxelis be included with PVax-Hib in the preferential recommendation for American Indian and Alaska Native infants? Next slide. Regarding initial workgroup considerations, it is important to note that 574 federally recognized tribes exist in the United States, and each are sovereign nations with their own norms, values, and culture. Workgroup members noted that listening to tribal communities is very important to understand the values and priorities of the communities that will be affected by any policy recommendation and to honor their tribal sovereignty. CDC's Office of Tribal Affairs and Strategic Alliances, OTASA, is helping facilitate our connection with tribal communities. Second, workgroup members noted that ACIP preferential recommendations must be evidence-based. Next slide. With the help of OTASA, CDC's National Center for Immunization and Respiratory Diseases held a listening session with tribal communities in January. The session had 80 attendees, including 9 from tribes or tribal serving organizations and 46 from Indian Health Service. Key questions and concerns raised by participants included whether Vaxelis will offer the same protection as PVax-Hib, the need to monitor for possible breakthrough cases with any change in vaccine policy, and safety and side effects. Next slide. Now I will summarize key workgroup considerations regarding post-dose 1 immunogenicity of Vaxelis among American Indian and Alaska Native populations related to Dr. Hammett's presentation. Next slide. Workgroup members emphasized several key aspects of the clinical trial. First, they noted that study enrollment included Navajo Nation and Alaska Native infants in Anchorage, but not broader American Indian or Alaska Native populations. Next slide. Second, they noted that the anti-Hib geometric mean concentration, or GMC, 30 days after dose 1 was non-inferior after Vaxelis versus PVax-Hib. The point estimate for the ratio of GMCs was 1.03, and the lower bound of the 95% confidence interval was above the pre-specified non-inferiority criterion. Next slide. Workgroup members noted that GMC differences on day 151 post-dose 1 likely reflect the 3rd primary series dose of Vaxelis versus only 2 primary series doses of PVax-Hib. Next slide. Workgroup members also noted that GMC titers were not available beyond day 151 to assess longer-term protection in this population. Next slide. Additional workgroup considerations are summarized here. Workgroup members noted that having a second preferred Hib vaccine option that is a combination vaccine may improve equity and the reliability of the vaccine supply for this population. Workgroup members also noted that the immunologic data are reassuring. However, there was some concern about generalizing to broader American Indian and Alaska Native populations, though there is precedent for this with the preferential recommendation for PVax-Hib. Workgroup members also noted the lack of direct vaccine effectiveness data and that the study did not collect titers beyond infancy, regarding whether Vaxelis might better prevent residual cases occurring before the booster dose. Finally, workgroup members had some uncertainty as to why American Indian and Alaska Native populations are particularly affected by changes in vaccination type, and they wondered if potentially more than just antibody response contributes to this. Next slide. In summary, workgroup members noted that including Vaxelis as a second preferred option for American Indian and Alaska Native infants may improve equity as well as the reliability of vaccine supply. They noted that post-dose 1 GMC of Vaxelis appears non-inferior to that of PVax-Hib among Navajo Nation and Alaska Native populations, with data gaps including studies in broader American Indian and Alaska Native populations, short-term efficacy, and longer-term immunogenicity and efficacy. The workgroup would appreciate input from ACIP members regarding these considerations. As a reminder, the workgroup's next step are for the grade assessment and evidence to recommendations framework to be presented in June, with plans for a vote in June as well. Next slide. I'd like to acknowledge the workgroup members and other contributors to the workgroup activities. Thank you. I'm happy to take any questions.
Thank you very much, Dr. Collins. Before I turn to the ACIP members and the other ex officios, I did want to ask if Dr. Clark had any additional comments he wanted to make about this, now that the work group considerations have been presented.
Thank you, Dr. Wharton. I appreciate that. No, I don't have anything additional to add.
Thank you very much. Any questions from ACIP members or comments on the work group proposal? I saw a thumbs up and some nods. I'm going to adjourn the meeting if nobody says it. So absent any more indications that committee members or ex officios have comments, I think we can take that the proposed work is definitely informative on the question, and there's support for the work group's approach going forward to June, would be my take on this. So thank you very much to Dr. Collins and Dr. Hammett and Dr. Clark for sharing with us his perspective as an IHS physician, as well as our ex officio from IHS. Really appreciate the questions and good presentations on this topic. Unless there's other business, I think we've completed our work for these 2 days. There's a lot of people to thank. I would particularly like to thank our ACIP members, as well as our ex officios who have really done a great job at this meeting, and as well as the speakers and the staff who have helped make our meeting happen. This whole process allows the committee to make timely, allows the committee to share and receive timely and transparent information that's visible to the public about vaccines in the decision-making process. I'm not seeing any additional business. I think we're ready to conclude our work, and so I will adjourn today's ACIP meeting. Thank you very much.
Dr. Wharton, we'd like to thank you and Dr. Daskalakis for your tremendous leadership of this meeting. Thank you.
Thank you very much.